và Dr. Quan Lee đến từ trường đại học Arizona của Hoa Kỳ. May I open our session today about instant restenosis. We have the chair with Professor Thạch Nguyễn, a very close college of our cardiovascular college in our country, and Dr. Quan Lee from Arizona, USA. We have two more speakers, Dr. Fahim Haider Jafari from Tan Tock Seng Hospital, Singapore, and Dr. Ho Lam from Ten Mun, Hong Kong, China. Please, would I invite Dr. Professor Thạch Nguyễn with the topic Applying Fluid Mechanics in Management of Coronary Artery Disease and Instant Restenosis. Please start.
Thank you very much. And I will speak in Vietnamese. Đầu tiên hết thì tôi xin cảm ơn các bác sĩ đã đến. Thì hôm nay một cái đề tài cũng rất là đặc biệt, đó là instant restenosis, tái hẹp trong stent. Thế thì mình có 4 bài. Bài thứ nhất là của một ông bác sĩ nói về cái dùng IVUS, cái chuyện đó mình biết. Bài thứ hai là của ông Quan Lee, là ông ta nói về vấn đề, ông nói một cái tổng quát về vấn đề instant restenosis. Cái bài thứ ba là nói về tip and tricks. Thế thì bây giờ với tư cách là một người đi học, thế thì tôi nói cái gì bây giờ? Thấy không? Mình thấy rằng là cái đó là cái người làm research, hay là cái mình là người đi học đó, thì mình phải xem cái gì, mình phải nhìn cái vấn đề một cách new perspective. Cái đó là cái tôi muốn nói tới hôm nay. Thế thì trong khi mà tôi nói tới đó thì là tôi hiện nay là tôi chê rằng là cái cách mình dùng cái current angiography picture, cái hình mà làm cái hình cái chỗ hẹp trong cái angiography, cái trục tim đó, nó là static, nó rất là tĩnh, nó rất là passive, nó không có active. Mình nhìn một cái lesion, mình không biết tương lai là cái gì, cái tương lai sẽ trở thành tốt hay là trở thành xấu, mình không biết được, mình chỉ biết là nó hẹp bao nhiêu chừng đó thôi. Tôi không đồng ý với cái cách nhìn như vậy. Thế thành ra vì vậy tôi nhìn cách khác, gọi là laminar flow. Trong khi mình nhìn cái dòng chảy như thế nào để mình biết được là cái lesion nó sẽ tiến ra như thế nào. Tôi nhìn cái ví dụ cái bình thường trước, đây là cái mình thấy đó, là chút nữa mình sẽ coi cái vấn đề này. Chút nữa thì sẽ có một bác sĩ nói vấn đề gọi là dùng IVUS. Thế thì bây giờ tôi thấy rằng là khi mà tôi nhìn một cái bệnh nhân mà họ có một cái chấn thương, một cái lesion nửa trung bình, mình không biết là cái lesion nó sẽ tốt hay xấu, thì tôi dùng cái flow ở trong đó. Bây giờ đây mình nhìn trước thì mình thấy rằng là hết rồi, sắp để cái dòng máu nó đi vào, cái dòng máu nó màu trắng nó đi vào, nó tới đây, đó, nó đang tới đây thấy không? Bây giờ khi mình xem xuống đây rằng là nó bị mắc kẹt đây hay không, nó có dòng chảy ngược lại hay không? Đây là tôi thấy là cái bệnh nhân này đó đi xuống mà không bị chảy ngược lại, thì cái laminar flow nó chảy hình tầng đó, nó chứng tỏ là cái lesion này không quan trọng và không có gây ra biến chứng in the near future, trong vòng 5 tháng hay 6 tháng. Đó. Nếu mà bây giờ với một cái lesion mà có normal laminar flow, never use lesion in the future, well controlled blood pressure, LDL cholesterol. Cái đó là cái tôi thấy là hiện nay là đang như vậy. Thế thì bây giờ cái bệnh nhân này đó, cái bệnh nhân này đó là cũng một cái bệnh nhân khác ra vào viện rất là nhiều lần, nhưng mà cái bệnh nhân này đó cũng có cái dòng máu chảy rất là tốt. Tôi rất là ngạc nhiên. Bây giờ mình thấy đã bắt đầu cái dòng máu trắng nó đi vào đó và nó đi xuống, và cái này rất là đặc điểm của cái này đó là nó đi, cái dòng máu nó sẽ đi vào cái đỉnh của cái curve. Từ đây nó qua cái đỉnh này, Cái đó là laminar flow nó đi như vậy đó. Mình coi đây. Đó, thế đi từ đỉnh này qua đỉnh này, xong sẽ coi nó tới cái đỉnh cái này. Đó là cái dòng máu đi như vậy. Đặc điểm của cái bệnh nhân này đó là không có reverse flow. Cái bệnh nhân này ra vào bệnh viện nhiều lần, nhưng mà không là phải là do là vấn đề tim. Bệnh nhân nó bị diabetes, bị renal failure. Cái thành ra vì vậy khi mà tôi nhìn thấy cái laminar flow mình biết rằng là cũng rất là tốt. Thế thì bây giờ khi mà làm angioplasty và stenting thì nếu mà trước khi mà đây là cái hình này, là đây là đó, bắt đầu là cái lesion nằm ở đây trước khi đặt stent. Đây là cái hình này là cái dòng máu đi vào 4 đến đây, hình tiếp theo là tới đây, và trước khi mình thấy đây là dòng máu chạy ngược lại. Đó, bây giờ đặt stent rồi mình sẽ thấy đi tiếp theo tới đây, tới đây, không có bị reverse flow. Tới đây ít thôi chứ không có bị nhiều. Thì khi thấy như vậy thì tôi thấy rằng là nếu mà bệnh nhân sau khi đặt stent mà có laminar flow, hiện nay nó vẫn là nghiên cứu, tại vì mình chỉ đặt cái Y không mà thôi, nó làm cái động mạch nó đổi chiều một chút là nó laminar flow lên. Thí dụ bây giờ các bác sĩ làm angioplasty thì nếu mà chưa cần phải đặt stent nữa, mình chỉ đặt cái Y thôi, nó làm thay đổi cái dòng chảy và nó thành laminar, chứ không cần phải là đặt stent. Thế thành ra vì vậy mà khi mà làm angioplasty, tại sao ngày xưa là không có stent, chỉ làm angioplasty mà 60% là vẫn tốt thường, 30% là tái hẹp, là vì nó thay đổi cái dòng chảy. Thế nhưng mà nó thay đổi không hết. Đó, thế thành ra vì vậy mà tôi thấy rằng là thế thành ra vì vậy cái hiện nay là cái nghiên cứu của tôi nói rằng là nếu mình làm mình có laminar flow after stenting thì lúc bây giờ mình tránh được in-stent restenosis. Là vì nếu bây giờ mình làm đặt stent mà bị tắc lại trong vòng 5 ngày, tất nhiên là do thrombus, là do cái kỹ thuật làm dở quá, nó bị thrombus. Nếu trong vòng 3 tháng, tất nhiên là intima hyperplasia, là do thì bây giờ cái chuyện đó nó bớt đi do drug eluting stent. Ngày xưa là bare metal stent thì là nó bị intima hyperplasia in 3 months. Nhưng mà cái mà nếu bây giờ mình mà hiện nay là mình có DES, drug eluting stent, thì nếu mình có laminar flow after stenting thì lúc bây giờ mình có thể tránh được cái in-stent stenosis. Nhưng mà tôi nói cái đó là một cái tôi đang làm research về cái đó. Thế thành ra vì vậy mà cái đó để nói cho các thầy, các cô và các bác sĩ đã hiểu. Thế thì bây giờ khi đó tới đây sẽ bây giờ đến cuối cùng tóm lại, thì nếu mà là mình thấy rằng là mình đặt stent mà có kết quả tốt, laminar flow, thì mình sẽ thấy rằng là cái bệnh nhân đó sẽ cái việc mà nó tránh được cái in-stent restenosis rất là nhiều. Cái này, sorry, cái hình nó bị ngược lại. Đó, summary. Thì hiện nay cái cách làm việc hiện nay, cái mà tôi chê là chụp hình cái angiogram, chụp hình phim không mà thôi, mà mình chỉ nhìn tới cái là teo hẹp chỗ nào thì cái hình nó rất là tĩnh, và passive tức là thụ động. Mình nhìn một cái hình mình chỉ biết rằng là trong cái courage study, ví dụ bây giờ nói rằng là cái vị trí này, cái chỗ hẹp này là 70%, nhưng mà mình không biết được là trong vòng 3 tháng nữa là cái 70% thành là 90%, hay nó thành 50%. Và tại vì có những cái lesion nó là slow growth, và có những cái lesion nó là fast growing, lớn mau. Cái thứ hai là trong cái hiện nay, không nói về vấn đề in-stent, laminar flow guarantee no new lesion in pattern coronary arteries. Thế thành ra bây giờ hỏi là thứ ba, mình có áp dụng được cái phương pháp này trong stent hay không? thì theo tôi thấy là hiện nay đang làm thì có thể làm được. Nhưng mà có một cái nữa tôi phải nói thật. Thí dụ bây giờ mình đặt stent mà cái stent nó không có áp sát vào trong cái động mạch vành, cái wall của cái tường của cái vách của cái động mạch đó, nó cũng làm laminar flow. Thế nhưng mà như vậy nó vẫn bị cái là thrombosis và in-stent restenosis, là vì cái stent nó không có áp sát, cái strut nó không có áp sát vào trong cái vách của nó. Và bây giờ hỏi câu hỏi nữa, thế bây giờ calcify artery thì như thế nào? Thế nên đó là một cái điều để research. Và cái cuối cùng nói rằng là beta blockers prevent late in-stent restenosis. Và tại sao vậy? Là vì cái beta blocker nó làm giảm cái huyết áp, làm giảm cái huyết áp thì nó làm cho cái reverse flow ít lại. Thế thành ra đó là những cái research tôi đang làm. Còn tất nhiên ba tác giả tới sẽ nói tất cả những cái thực tế trong hiện nay như thế nào. And thank you very much.
So thank you, Professor Thạch Nguyễn, for a very interesting topic. And we move to the next presentation with Dr. Fahim Haider Jafari with how to assess stent restenosis by intravascular imaging. Please continue.
Are you going to play my talk, the video?
I saw video đúng không em?
Hello. Thank you for the invitation to give this talk today. My job over the next 10 minutes or so is to talk to you about the role of imaging in assessing in-stent restenosis. I don't have any conflicts of interest related to this talk. I think the first question you always have to ask is, how do we define in-stent restenosis? And sort of it's been variably defined, but the academic research consortium is the definition that we use the most commonly, which basically states that any luminal narrowing of more than 70% within 5 millimeters proximal or distal to the stent is considered in-stent restenosis, or a luminal narrowing of at least 50% plus evidence of ischemia, either symptoms or a positive stress test or FFR. Now, how do we classify in-stent restenosis? The most widely accepted is the Meran classification, where you can look at in-stent restenosis as focal or diffuse. And if it's focal, there are different kinds of focal in-stent restenosis. In each of these, the lesion is less than 10 millimeters, and it's either located up here in the articulation point between the two parts of the stent. This is the old Parma-Schatz stent, which we don't use anymore, or focal in-stent restenosis at the distal end or the middle of the stent or at both ends of the stent, or any combination. Diffuse in-stent restenosis has in itself a few categories, starting from this one, which is type 2, where the lesion is more than 10 millimeters, but does not extend beyond the margins of the stent, to type 3, where the lesion is more than 10 millimeters, but also extends beyond the stent on either side. And then finally, type 4 diffuse ISR, which is the worst kind, where you basically have occlusive in-stent restenosis and there's no flow. Now, is in-stent restenosis a problem? And the answer is yes and no. On the one hand, the incidence of in-stent restenosis from the earlier times of stenting, when we were using bare metal stents, has plummeted, and now it's in the single digit, 3 to 4%. But it is 3 to 4%, and that's 3 to 4% of a lot of patients who are undergoing drug-eluting stents. We also know from a lot of data, pooled data from 19 studies, showing that basically stent-related events continue over the life of the patient. It doesn't really stop. And so if you look at it over here, after the first year, if you look at the first generation drug-eluting stents versus the newer generation drug-eluting stents, there is about a 2% per year event rate, no matter what kind of stent you look at, whether it's the old generation DES or the newer generation DES. The numbers are lower with the newer generation drug-eluting stents, but there is no plateau, and it doesn't matter whether you use, durable polymer or bioabsorbable polymer or no polymer. The event rate does not seem to plateau. And a lot of these events are related to in-stent restenosis and we will talk about the various kinds. So what are the reasons to adopt imaging in patients with in-stent restenosis? And that takes us back to the fact that imaging helps determine the mechanism of ISR. And then, of course, it sort of may guide optimal therapy. Of course, it's important to then talk about what are the mechanisms of ISR. And the mechanisms are as follows. You have mechanical issues with the stent, vis-a-vis the stent could be underexpanded or it could have recoiled. The stent could have fractured, or you may have gaps or geographic miss between stents are some of the mechanical issues that can cause ISR. On the other hand, a large number of ISRs are due to biological issues where the stent is well expanded, there's no problem there, but the biology hit you in the face. For example, you could develop neointimal hyperplasia and neoatherosclerosis. Now, what are these? Let's just look at these concepts in a little bit more clarity. So for starters, when you talk about stent expansion, on the left side is an underexpanded stent. That is the vessel size. The yellow is the plaque. And you have a stent that is deployed that has a small minimal stent area. It is underexpanded, but it is well opposed. Okay. Now, this is different from a underexpanded stent that is malopposed. So you can see here, the vessel again is big. The stent is expanded, but it is not well expanded. It is still quite small, but also the stent is not fully opposed against the vessel wall. Both of these are bad, but the badness is driven by the expansion or the stent cross-sectional area, not the malapposition. The malapposition itself is not a huge problem when it comes to restenosis. Now, on the flip side, here is a well-expanded stent that is also well opposed. It is expanded, you have a good stent area, and it is sort of stuck to the vessel wall. But the example to the right of that is a well-expanded stent. You have a good stent area, but it is not fully opposed to the vessel wall. So there is some degree of malapposition. And it turns out again that malapposition itself is not a problem when it comes to restenosis. It is only the stent area. So the restenosis rate over here would be quite low. Malapposition does lead to other issues, and we can talk about those in the discussion, but does not lead to in-stent restenosis. Now, when we talk about mechanisms of in-stent restenosis, we talked about underexpansion. What about stent fracture and stent gap? And so stent fracture is an interesting entity where you deploy a stent, and due to the hinge movement of the vessel, often at an angle, especially the right coronary artery that moves a lot, the stent will basically break. And when it breaks, you end up with a gap between the stents, and this can be the site of in-stent restenosis. Sometimes another thing that could happen is that if the stent is either in an aneurysmal segment or an aneurysm forms down the line around the stent, you may get kinking of the stent, and this could lead to stent fracture. Again, looking at the causes of in-stent restenosis, let's look at some of the biological issues. And we said neointimal hyperplasia and neoatherosclerosis are the two big ones. Now, what are they? Well, neointimal hyperplasia is vascular smooth muscle cell proliferation within the lumen of the stent. So smooth muscle cells come from the media into the stent and create a new layer. It is caused by vessel injury following mechanical stretch or rupture of the internal elastic lamina and medial dissection. So it's an injury response. And so it's primarily a non-specific inflammatory response to vessel wall injury. And so if you look at it over here, This is a well-expanded stent, deployed, all good. And when you, in follow-up, this patient may develop new intimal hyperplasia, which is this sort of tissue growth within the stent that compromises the lumen. The stent itself is good, but the lumen is still compromised. Now, on similar lines, neoatherosclerosis is essentially atherosclerosis developing in the neointima. So it is accumulation of foamy macrophages within the neointima, with or without a necrotic core, and possibly even calcification. So it's basically atherosclerosis developing in the neointima. And it can occur, it typically occurs years after stent implantation, and can even have a thin cap like true atherosclerosis, and can rupture, leading to ACS. And it is responsible for late stent failures in DES. The mechanism involves incomplete regeneration of the endothelium. So the endothelium doesn't fully cover the neointima, and that leads to what is theorized as an excessive uptake of circulating lipids, leading to accelerated atherosclerosis in the neointima. And neoatherosclerosis is less frequent in bare metal stents and more frequent in DES. Now, this is sort of illustrated over here. This is a stent that has just been deployed. Down the line, the patient develops neointimal hyperplasia. And within this neointimal hyperplasia, they may then develop neoatherosclerosis, which is atherosclerosis now, and this can lead to plaque rupture. And this is also illustrated over here. Here you have a stent, a lesion that was stented, good stent expansion, and you develop a thin coat of neointimal hyperplasia, good lumen, everything good. But sometimes this doesn't heal so well like this, and what may happen is you develop, you develop this neointimal hyperplasia, but the neointimal hyperplasia is not fully covered with endothelium like it is over here. So when it is not fully covered by endothelium, you have leakage of lipids into the neointima, and that leads to the formation of neoatherosclerosis within this neointima that can develop a necrotic core, plaque rupture, and compromise the lumen, just like normal atherosclerosis does. And as you can see, that at any given time, when the patient has ISR, multiple mechanisms can be at play. There can be stent factors. The stent could be underexpanded. There could also be neointimal hyperplasia or neoatherosclerosis. So all of these multiple things could be at play at any one given time. So when we then talk about imaging for ISR, the expert consensus guidelines recommend imaging to determine the mechanism of ISR. It gives it a 2A. And the purpose is to not only determine the mechanism and pattern of ISR, but potentially treat it in a more optimal way with potential improved outcomes. Now, I say potential because it's important to understand that there are no randomized trials that have shown that there is an incremental benefit of treating ISR using imaging, but the general consensus is that it is beneficial. So now when we talk about imaging, let's talk about the first form of imaging, which is stent boost or stent enhancement. Most of you, everybody has it in their labs, whether it's stent boost or stent viz. And it is very useful to determine inadequate expansion, as you can see over here, and even stent fracture. And in this next diagram, you can see that here you have actually one stent, but it looks like it's two, and that's at the site of this restenosis. And what has happened is essentially the stent had fractured. And sometimes stent fracture can be seen better with stent boost rather than even IVUS or OCT, because sometimes this gap is very small. And this was then stented in this particular case report and with a nice result. Another example of stent fracture, you can see, seeing it very well on stent boost over here. And the same is being used to then implant a stent to cover the gap. What about IVUS? And IVUS is very good for determining undersizing of the stent. It is good for determining stent fracture when you see gaps, although high def IVUS is probably better than the 40 megahertz IVUS. It is useful to determine neointimal hyperplasia and calcific neoatherosclerosis, but is not very good for tissue characterization. So can you tell non-calcific neoatherosclerosis from neointimal hyperplasia? I think it's a bit challenging using IVUS, especially with non-high def IVUS and even with high definition IVUS. And so just to show you an example, This is a stent that is well expanded. And if you look carefully, this is neointimal hyperplasia, this sort of grayish homogeneous tissue. But it's not so easy to see. You can get some value with the tissue characterization with the volcano Phillips IVUS system. But as you can see, it is not that easy to see. On the other hand, when you have neoatherosclerosis, it is impossible to know whether this, for example, is neoatherosclerosis or neointimal hyperplasia unless there is calcification. And so in this example, you can see the stent, which is out here. So the stent is well expanded. And in the stent, you see calcium. This can only be due to calcific neoatherosclerosis. And you can see over here in this part of the vessel, there is almost a 270 arc of calcium. But within the stent is way up here. This is in the stent lumen. And up here, you can see almost a 360 arc of calcium that is obscuring the stent. The stent is somewhere out here. You can see struts here, here, and here. So you know that the stent is somewhere out here. But the calcium, due to this calcific neoatherosclerosis, is obscuring the stent. And in this example, it was dilated and then restented. OCT, on the other hand, is better than IVUS for determining stent undersizing, stent fracture, neointimal hyperplasia, as well as neoatherosclerosis, both calcific and non-calcific. And you have much better tissue characterization. And just to illustrate the point here, this is an example of an underexpanded stent with neoatherosclerosis. You can see with neointimal hyperplasia and neoatherosclerosis. So you have the stent. The vessel is much bigger. The vessel is way out here, a smaller stent. And then in the stent, you see this tissue growth. And this golden yellow looks more like neointimal hyperplasia. And then you see this sort of, low attenuation dark segment, which looks more like lipidic neoatherosclerosis. So a combination of an underexpanded stent, neointimal hyperplasia, and neoatherosclerosis. On the other hand, here you have two other examples where you have pure neointimal hyperplasia. So this is the stent, well expanded, and you can see this growth of tissue in the lumen of the stent, nice golden yellow, homogeneous, bright. This is neointimal hyperplasia. And then if you look to the right of that, you have the stent way out here. And then you have this sort of less homogeneous, more heterogeneous tissue in the lumen, growing into in the lumen of the stent. It is heterogeneous, not homogeneous and golden yellow like this. And you can see that there is a thin cap, over here. This golden yellow thing is a thin cap, like you see in atherosclerosis, and it could rupture, causing plaque rupture. And then if you look very carefully, you can see foamy macrophages in the tissue, which is, again, consistent with neoatherosclerosis. And this is another example. And over here, just to give you another example, you have neointimal hyperplasia distally, and you have lipidic neoatherosclerosis proximally, where you have a thin cap, golden dark, golden yellow thin cap, and then lipidic neoatherosclerosis, which is literally obscuring the stent. So a combination of neointimal hyperplasia and neoatherosclerosis. And this is sort of showing the same thing. So in the interest of time, I will fast forward. So then here's the algorithm that you use based on imaging. Once you perform imaging, if there is a mechanical issue, you need to address that by either redilating or shockwave or atherectomy or laser. An underexpanded stent, fix it with the mechanical solution. But if it's a biological issue, either neoatherosclerosis or neointimal hyperplasia, then your choices are to either re-stent or use a drug-coated balloon. And in general, if you have neointimal hyperplasia, it is reasonable to dilate and then use drug-coated balloon. If it is neoatherosclerosis, both strategies, re-stenting as well as drug-coated balloon, are reasonable strategies. I tend to re-stent many of them because often the plaque is unstable. So it is kind of, you're stenting it to fix the biology of the unstable plaque. So if I was to conclude, ladies and gentlemen, despite declining incidence, in-stent restenosis remains a significant problem. And the mechanisms include mechanical issues like underexpansion, fracture, as well as biological issues like neointimal hyperplasia and neoatherosclerosis. Imaging, both with stent enhancement and intracoronary imaging, helps determine the mechanism and how to treat. And on balance, OCT imaging may have an advantage over IVUS in most of these cases. Ladies and gentlemen, thank you very much for your attention, and I apologize for going over my time a little bit.
We talk about the mechanism of instant restenosis. Do we have any question, any discussion from the audience?
Yeah, I have a question for Professor Thạch Nguyễn and also for Dr. Fahim, because we have some theory about the laminar flow. When you have a laminar flow, that means physiology, and that means we can have a good result for the future after stenting, because sometimes we have the bifurcation or some tortuous vessel that make the turbulent flow, in contrary of the laminar flow. And in some case of OCT or IVUS, we can see the under-expansion or malapposition that can make turbulent flow. What about the common point between this? Maybe some imagery in OCT can be related to the laminar or turbulent flow, and then can give in restenosis for this. What about this? Thank you, Mr. Professor Thạch Nguyễn.
Tôi xin tóm lại cái ý của cái ông giáo sư bên Singapore. Cái thứ nhất, ông ta nói rằng là cái mechanism của instant restenosis có 4 cái: underexpansion, fracture, malapposition or stent gap. Đó là một. Cái thứ hai là ông ta nói là cái biology khi mà phải dùng cái IVUS hay là OCT đó có hai chuyện. Thứ nhất là coi rằng là đó là neo-intimal hyperplasia hay đó là neo-atherosclerosis. Neo-intimal hyperplasia tất nhiên là nó chỉ có dày lên thôi, do cái gọi là những cái tế bào mà gọi là sẹo đó. Còn cái kia đó là cũng là tế bào sẹo, nhưng mà bây giờ nó lại có cái ghép ở trong đó và nó tạo ra một cái lesion mới. Cái đó là hai chuyện. Thế thì cái điều trị đó thì là lúc bây giờ đó thì bây giờ nếu mình dùng IVUS hay là mình dùng imaging là mình dùng IVUS đó, nếu mình thấy là đó là gap hay là đó là fracture hay là underexpansion thì mình mở nó ra. Nếu bây giờ mình thấy hyperplasia thì cái chuyện đó là ông ta dùng cái DCB hay là dùng cái DCB hay là dùng DES. Thế. Có một cái slide trong cái slide mà ông ta không nói tới. Có trong slide nhưng không nói tới. Đó là no RCT proof for imaging that can improve the outcome. Tất nhiên là không có một cái RCT là randomized clinical trial chứng minh rằng là nếu mình dùng imaging thì mình sẽ làm tốt hơn. Coi lại cái slide đó, có một cái slide nói như vậy, cái khúc dưới. Thì cái chuyện đó là rất là dễ dàng khi mà người ta lecture. Nếu bây giờ mình muốn chú trọng một cái đề tài gì đó mà mình không muốn nói về cái xấu của cái đề tài của mình thì mình để trên đó mà mình không nói ra. Nhìn lại tôi chắc chắn là có, thấy không? Thế thì bây giờ câu hỏi của thầy Anh đó phải không? Đúng là Hoàng Việt Anh thì nói rằng là bây giờ nếu mà tôi nói như vậy thì là ông thầy nói là tôi chú trọng tới cái vấn đề cái flow thì bây giờ giải quyết như thế nào? Thấy không? Thì bây giờ cái thứ nhất, intimal hyperplasia. Ngày xưa khi mình dùng bare metal stent là bệnh nhân nào cũng có intimal hyperplasia. Và cái intimal hyperplasia là nó tăng lên và giảm xuống, đó là living tissue. Chứ đâu có phải là nó là đồng tế bào chết đâu. Thành ra nhiều khi mình chữa xong rồi, mình xem lại thì nó xuống lại. Thì cái đó thành ra vì vậy mà cái intimal hyperplasia thường nó chỉ xảy ra 3 tháng đầu tiên thôi. Thế thì bây giờ cái câu hỏi tiếp theo là tại sao lại có neo-atherosclerosis? Giờ cái stent nó mở rất là tốt, có intimal hyperplasia Tại sao bây giờ nó lại thành ra có một cái lesion ở đó, nó có cả một cái hồ chứa cholesterol trong đó. Là rất là chú trọng, rất là quan trọng trong vấn đề cái người đó phải dùng cái cholesterol level low thì nó mới không tạo ra cái neo atherosclerosis. Và cái điểm thứ hai nữa là phải là good blood pressure control. Là vì cái blood pressure nó làm injury cái intimal layer ở trong cái stent thì nó mới làm nó làm hư cái chỗ đó. Lúc bây giờ cholesterol nó mới đi vào. Thành ra vì vậy bây giờ mình hỏi rằng là cái chuyện đó là tôi cũng hiểu ý kiến của thầy Anh đó. Thế thì nhưng mà cái chú trọng nhất là thứ nhất là phải be sure about cholesterol control, be sure about blood pressure control after stenting. Đó, thế nên nếu mình làm như vậy thì nó sẽ giảm cái chuyện mà tạo ra cái neo atherosclerosis. Cái câu cuối cùng của thầy Anh nói rằng là đúng, cái câu đó là hỏi là đúng, là tại vì bây giờ mình bị intimal hyperplasia thì cái flow nó là laminar hay là turbulence? Nó là laminar. Tại vì nó rất là đều, nó rất là, ví dụ bây giờ mình có một cái stent dày 4mm, và bây giờ 1mm là intimal hyperplasia thì cái lumen của nó ít nhất là 2,5. Cái flow nó rất là laminar. Thế nhưng mà như vậy thì câu hỏi rằng là cái laminar như vậy, cái bệnh nhân này có thể tạo ra stent, cái lesion nó có bị vỡ ra không? Nó không vỡ ra. Và tại vì nó là laminar mà. Thế nhưng bây giờ nếu mà nó là neo atherosclerosis, uncontrolled high blood pressure, uncontrolled high cholesterol level và diabetes, smoking, chắc chắn là vỡ. Đó, thế thành ra vì vậy mà cái chuyện đó thì dĩ nhiên cái ý kiến của tôi là nó chú trọng vấn đề research, nhưng mà khi mà coi cái bài của ông thầy này nói, ông ta nói rất là đầy đủ và cho mình thấy. Nhưng mà có một cái khó là họ rất là chú trọng tới cái dùng cái technique rất là đắt tiền ở Việt Nam, nó sẽ mình làm được. Đâu phải chỉ có Việt Nam, tất cả các nước khác đều bị hết, đều phải như vậy hết chứ đâu phải là chỗ nào. Khoan, he is a great intervention cardiologist in Arizona. Dr. Jeffrey talked about IVUS or OCT after in-stent restenosis. Now in your hospital, do you do IVUS or OCT after every case of in-stent restenosis?
Do IVUS or OCT. Obviously, there are clinical limitations. If there's renal disease, then we don't do OCT, we go for IVUS. We find, as Dr. Jaffrey had mentioned, that OCT provides better tissue characterization. But I think the most important bifurcation point really is undersizing. Most people, when they place stents historically, have actually undersized most of their stents. And in my lecture that I'm about to cover, I think that's probably the most important thing to figure out, whether your stent is undersized, in which case IVUS is actually very good for that.
But do you do every case of in-stent restenosis imaging?
Yeah, we try to do every case to truly understand what's happening. Because if you don't understand undersizing and you don't fix undersizing, no matter what you do, things will not, get better. Because as we know, when you restenose, the probability of restenosis again is very, very high.
I would agree with that.
Sau mỗi in-stent restenosis thì ông ta đều làm cái IVUS hay là OCT. Và ông ta nói là nếu mà OCT thì theo ông này là hay hơn. Nhưng mà nếu mà IVUS thì thường là nguyên nhân ông ta nói là dễ bị là do bị undersizing, mình đặt cái stent nhỏ quá. Thì thường như vậy là IVUS tốt hơn. Thank you very much.
Yeah, what about you, Fahim? I just heard you there.
Yeah, Kwan, thank you. I agree with what you said. I mean, I think we try to image as much as possible. And the idea is that you try to understand what the mechanism is vis-a-vis expansion, which is, as you rightly said, the most common reason for in-stent restenosis. But it's also, you'll be surprised many times you think the stent was undersized and you go in and you just find that it's a bunch of neointimal hyperplasia. So I fully agree that if it's feasible, you should image every time in this particular subset, in-stent restenosis.
It is great for him to listen to your talk. Now, do we have any question for Dr. Jeffrey in Singapore?
Fahim, I had a question. You mentioned malapposition earlier on being not as big a deal. However, if you do detect late malapposition, I know in early malapposition we try to correct it. In late malapposition, even though it has not really been shown to aggressively be associated with long-term MACE, do you still correct late malapposition?
So it's a good question point, Kwan. So for the audience, early malapposition, in other words, you deploy a stent and it's not fully opposed against the wall, is not a problem for restenosis. As long as the stent is well expanded. On the other hand, it can be a technical issue in the sense that if the stent is not fully against the wall and you end up coming back to rewire it for whatever reason, your wire could go underneath the stent and you could end up with problems. So we try to correct any malapposition if it's there so that you future-proof your intervention. And this is as far as acute malapposition is concerned. Now, what Kwan is talking about is late malapposition, which is you deployed a stent, the stent was fully opposed, and for whatever reason, you come back and look at the stent, months later or years later, and the stent is still well expanded, but the vessel wall has dilated. And that is different. That is essentially vessel toxicity. And so the vessel basically developed dilatation around the stent, and that is called late malapposition. That is associated with worse outcomes, and it is related more to the toxicity that the vessel has experienced. And I think it's unclear whether correcting it or not makes a difference to outcomes. If there's a lot of malapposition, I will probably correct it, but I'm always unsure whether that's going to make a difference to outcomes because the outcomes are driven by the reason why the late malapposition happened, which is vessel toxicity, and your long-term risk is the risk of late stent thrombosis, amongst other things.
Thank you very much. Do we have any other question for Dr. Jeffrey? Nào, tôi xin hỏi một câu nghe. Hôm nay tôi có nói tới là ông ta không nhấn mạnh tới CT và imaging. Thì mình hỏi ông, được không? For him, I have a question for you. In your slide, you mentioned that we have no RCT to prove that using imaging will improve the clinical outcome. Can you talk about us a little bit about that?
Yeah, so I mean, it's not been formally studied in the in-stent restenosis population. In other words, nobody's taken a bunch of ISR patients and then randomized them to just angio-guided versus imaging-guided and then looked at the outcomes. There is a general consensus that when you image, you get to know the mechanism better and you get to therefore treat it better. And the consensus document gives it a 2A, class 2A indication because of that. I think it's just important to recognize that, yes, we don't have randomized trials, but the information you get from imaging is quite substantial, and it is likely that it will improve outcomes. And anecdotally, I can tell you that many a time, we've gone in and imaged a lesion, and I'm sure Kwan will hopefully agree with that. We've imaged a lesion. We thought it would basically just be, neointimal hyperplasia. We even put a cutting balloon on the table, just ready to go in. And when you go in, the stent is undersized. There is virtually no neointimal hyperplasia in the stent. It's just that the stent is small. And that dramatically changes your outlook because the treatment there is to just blow it up with a bigger balloon and no need to do cutting balloon and other things. So I think the short answer to your question is that yes, there aren't randomized trials, but there is enough compelling biological and observational data to suggest that we should be using imaging if we can.
Fahim, thank you very much for the beautiful explanation. We buy your explanation. Okay. Tôi có nói với ông ta là đó, thì bây giờ tôi là nghe rõ ràng ông ta nói là không có RCT, nhưng mà cái common sense hay là cái general consensus là đồng ý để làm như vậy. Và cái recommendation là 2A, you see. And thank you very much.
Thank you.
Thank you. So the next speaker is our very close friend, Dr. Quan Lee from Arizona, and he will talk to us about what new in management of in-stent restenosis in 2022. Có gì đặc biệt trong cách điều trị của in-stent restenosis của năm 2020-2022. Thank you very much.
Thank you, Dr. Takman. It's such an honor and pleasure to be back here again. Can I have my slides up, please? Hi, can I have my slides up, please? Okay, so the topic, my title today is Management of In-Stent Restenosis, What's New in 2022. We're going to be obviously reviewing some of the material that was covered by Dr. Jaffrey and his excellent talk so far, and then expand on some of the other concepts that have emerged in the last few years. So the first thing we'll look at together is early definitions of in-stent restenosis, the Moran classification that was talked about. We'll examine bare metal stent versus drug-eluting stent ISR. And then just very briefly, once again, touch again on characterizing ISR etiology with intracoronary imaging. And I think we need to delve a little bit of detail in the treatment of stent under expansion. We'll look at ACC ESC guidelines. We'll look at DCB versus DES use. And then look at a pragmatic approach of how you should approach in-stent restenosis as a whole, and then very briefly understand the concept that DAPT after ISR PCI is different from regular DAPT durations. So this is once again from Roxana Meran's classical paper from Circulation in 1999, where they based the definition of in-stent restenosis on angiographic patterns in bare metal stents. Initially, ISR had been just described as focal or diffuse, whether less than 10 millimeters or greater than 10 millimeters, and Roxana Meran built on that definition by including subsets. She figured out that there was focal ISR, type 1A, there was ISR at the margins of the stent, there's ISR within the body of the stent at articulation points, and then multifocal ISR, and then also showed that there's diffuse intrastent and then proliferative, where it extends beyond the edges of the stent, and then obviously the chronic total occlusion. And what they showed very clearly from clinical outcomes, there's no categorizations are not meaningful when they are not tied to clinical outcomes. And what they showed very clearly is that the target lesion revascularization percentages go up increasingly with the different types of angiographic restenosis. So very quickly, we should also once again look at this famous diagram from Madhavan et al. And show that ISR BMS peaks within the first year. Within the first year, you're going to get neointimal hyperplasia in bare metal stents. And then after that, it switches over and becomes neoatherosclerotic disease with a constant rate of failure of around 2% per year. The same does not true happen for drug-eluting stents, and really for drug-eluting stents, it's just one long development of neoatherosclerosis. ISR BMS is more frequently diffuse or proliferative, while DES is more focal or age-related. And then with ISR DES, there's more neoatherosclerosis, and it occurs earlier. So once again, it is extremely important. I think this is one of the most recent concepts to emerge from the ISR conceptualization, is that you have to recognize that ISR is heterogeneous and the treatment must be tailored to the specific form of ISR, even though, as Dr. Jaffrey mentioned, there have been no randomized trials. So both the 2021 ACC and 2018 ESC guidelines recognize this by the 2A recommendation for intracoronary imaging to determine the exact mechanism of ISR. Evan Schlofmitz and Ron Waxman, to build on Roxana Meran's initial classification status, proposed a new classification status in 2019 called the Waxman ISR classification. And there, they very strongly make a point that you must recognize under expansion and it must be treated prior to you using other therapies. So this is the new definition proposed based on intracoronary imaging findings and etiology of ISR. The first, type 1, is mechanical. You must treat the mechanical first. And then type 2 is the biologic, neointimal hyperplasia, neoatherosclerosis, non-calcified or calcified. And then you have the mixed pattern with combined mechanical and then chronic total occlusion. And then they are very careful here. They have a new category that's not previously described where you have ISR with greater than 2 layers of stent. I think that's very important to recognize because When you have greater than 2 layers of stent ISR, your rate of failure of therapy is very high compared to just 1 layer, and maybe those should be approached differently. So within type 2, these are the intracorneal imaging examples that Dr. Jaffrey showed us earlier, and then also they link that to recommended ways of treating each of these forms. So just to go back here, always the best treatment is prevention. The initial PCI predisposes towards ISR. If you have underexpansion and you haven't resolved your corneal calcifications, if you have ISR, if you have bifurcated lesion, osteal lesions, CTOs, if you fracture your stent in calcified lesions, your ISR rate will increase. And then if you leave stent gaps or have long lesions in multiple stents, that also predisposes to ISR. So use of intracorneal imaging before you put your stents in, as we have clearly seen recently with IVUS, is a good idea because it will reduce future ISR. So prevention first before treatment. When it comes to treatment of stent underexpansion, high pressure plain balloon angioplasty is the most important method of treating this. Use short non-compliant balloons, but take care to avoid stent age-related complications or slippage like watermelon seeding of the stent. Cutting or scoring balloons can help reduce slippage, and there was a trial that showed that it was synergistic effect if you use a scoring balloon followed by a drug-coated balloon. The new technology of intravascular lithotripsy can be helpful in stent regret or resistant underexpansion. This is off-label, but it definitely works. We have used that before, and obviously the problem here is that's a very expensive way to do this. Rotational atherectomy can be helpful in calcified neoatherosclerosis or resistant underexpansion, but obviously, if you're going to put a rotablator through a stent, you must take care with burr entrapment or metal shaving embolization. Lasers can be helpful. I don't know whether you have laser in Vietnam, and we use it sometimes. And when we do it within stents to expand, we actually use contrast in conjunction with laser, which creates micro explosions that create shock waves. And then orbital atherectomy, for those who have it, there's definitely less data and possibly more risk of burr entrapment. So the revascularization guidelines, basically for ACC, they basically recommend DES for in-stent restenosis. And there used to be a question as to whether we should change drug in paclitaxel. Should you use a limus drug? But this has subsequently been proven to not be true from the ISR trials. We still do not have drug-coated balloons in the United States, although I think Medtronic is working to correct that. And so I know that in Asia and in Europe, you've had drug-coated balloons for many more years compared to us. The other two recommendations from the ACC are to consider CABG in recurrent ISR just because the outcomes are so poor, and then that you can use brachytherapy, and I don't think you have that in Vietnam. But that is, even though it's available in the United States, it is rarely used because only a few centers still perform brachytherapy. Within the 2018 ESC guidelines, ESC Europe being slightly more advanced than the United States in this regard, have had drug-coated balloons as a 1A recommendation in addition to drug-eluting stents since 2018. And once again, they recommend considering CABG in cases of recurrent restenosis. What are the treatment modalities for in-stent restenosis? In network meta-analysis, we clearly see that EES versus DCB, the drug-eluting stent, is still the best. And second is drug-coated balloons. Cutting, scoring balloons are useful, but they're still not as good as drug-coated balloons. And then use brachytherapy for recalcitrant cases. For rotablator, etc., the evidence is definitely limited, but if you have calcium and you have no choice but to use it. When should we use DCB versus DES? Things that favor the use of drug-coated balloon is ISR with a less aggressive pattern, i.e. focal ISR, with good lumen expansion after balloon dilatation, ISR of bare metal stents, you get a multi-layer ISR, and obviously patients at high bleeding risk who cannot tolerate DAP, as well as major side branch involved to avoid jailing of side branch. When should you consider DES? If you have a very aggressive pattern of ISR at high rate of recurrence, if you have ISR already of a DES, if you have single layer ISR, or presence of a stent-related mechanism like stent fracture or stent gap, that's when you should consider ISR. And obviously, if your stent will not expand, stents are better at maintaining expansion. So here is a recommended pragmatic algorithm from Samin Sharma's group, published very recently in JACC. They basically say that one layer ISR should be treated with repeat DES, DCB. They say avoid repeat stents in two layer ISR, perform DCB if possible, and then recognize that there are some high-risk subsets that really favor CABG. If you have left main ISR, the outcomes for left main ISR are very poor, and obviously the implications are poor as well. If there's bifurcation and multi-vessel disease, consider CABG. And brachytherapy is helpful, but in patients who get brachytherapy, you cannot put another drug-eluting stent. There's a high thrombosis risk long-term because the tissue dies, and you basically have very long-term strut non-coverage. When it comes to DAP duration after ISR PCI, it's important to remember that in general, you want to have more aggressive DAP therapy, and you don't follow the same traditional rules with regards to pulling back on your DAP therapy. So to conclude, the main concepts are to use intracoronary imaging to identify the mechanism of ISR. If stent under expansion is present, it must be addressed. Repeat DES is the first line, and then DCB is the second line. Understand the algorithm and the use of other adjunctive therapies such as cutting, scoring balloon, intravascular lithotripsy, and rotablator. Know that your DAP duration should be longer. And I know we are interventionists, but don't be afraid of CABG. We should be still considering CABG in appropriate cases. All right, thank you.
Thank you, Mr. Kwan Lee. We move to the next presentation. Before that, we have the discussion afterward. The next presentation with Dr. Hồ Lam with the tips and pitfalls to redo PCI for in-stent restenosis. Bài tiếp theo sẽ là của bác sĩ Hồ Lam đến từ Bệnh viện Hồng Kông, Trung Quốc, với chủ đề là các mẹo để can thiệp lại tái hẹp trong stent. Xin mời.
Hello, everyone. I hope everyone can hear. It's my great pleasure to join the meeting. I think after Kwan Lee's presentation, Professor Kwan Lee's presentation, there's not much left to talk. He gave a very detailed review. And for my talks, I am going to share some practical aspects, some tips for ISR management. All these are my personal views and experience sharing. So for PCI to ISR, the most important, I think, is to assess the nature, the cause, everything clearly before you go for further PCI. And that means that you have some planning, some idea on your mind for the failure before you go to the next step. Otherwise, you may enter in the failure mode again. So although the guideline there's no randomized trial, I still prefer intravascular imaging and stent boost to assess. So there are two important points while you're doing the assessment. What are you looking for? There are two important points. One is to see if there's any mechanical problems. For example, under expansion, malposition, calcium nodules, stent fracture, any stent gaps. If there's a mechanical problem, you must settle those mechanical problems. Otherwise, you will always go into failure mode, no matter you use DES or DB or whatever DB or whatever DES. And the other important point is to classify your ISR. Professor Kwan Lee had give us some idea on different classification. I want to share my classification. My classification on ISR is very, very simple. It's in-stent ISR or out-stent ISR. And I use this to choose DB or DES. So I will further explain. So in in-stent ISR, I will prefer DCB. What is in-stent ISR? Like this focal, in-stent, all the ISR, all the hyperplasia is in-stent. Then I call it instant ISL. And for this case, I will well prepare it with cutting balloon, with NSC, with high pressure balloon or whatever, and then DCB. And the other type is outstand ISL, very easy to remember. Now, we have a different picture to illustrate. For those cases with the ISL hyperplasia with stenosis outside the stent, no matter it's at the proximal edge, distal edge, or both, or there's a stent gap. In terms of hyperplasia with stenosis outside the stent, I will consider to use DES because DCB, drug coating balloons, may not be a good idea. So why? Because DCB is effective and good at prevention of neointimal hyperplasia. However, it's not good for recoil and negative remodeling. For those ISL, there are mainly two mechanisms. One is hyperplasia, one is negative remodeling plus recoil. So drug-eluting balloon is just good for hyperplasia. You need stent to prepare recoil. So many years ago already, we know that negative remodeling is not uncommon in non-standard section for restenosis. And if you go back to very long time ago in circulation, this Japanese doctor published the paper for the cause of the restenosis after the ballooning, everything it happens around after 6 months. They will have significant negative remodeling recoil and then causes restenosis. So if there's lesion outside the stent, no stent to keep to reduce, to treat the recoil, to treat the negative remodeling, it's better to have stent. To treat the ISL, the first thing is case selection. For instant ISL, I will use DCB. If the hyperplasia with stenosis involve outside the stent, then I will choose DS. That's my usual practice. Of course, there's no randomized control trial, and in fact, you can see the guideline. All are level of evidence C. And for DCB selection, it's also important. Although you may think that all DCB is the same, but no, that's not true. Like this DCB is out of the market already. So you had never seen a study that give worse outcome than Texas. And this is the first or the only study I know that compared to Texas, and it lose. So not all the DCP are the same. And so for my talk, I cannot find any randomized trial, but I can find registry data to support this. This is the registry for the DCB. It's around 1,000 patients. Now, in this registry, 80%, around 80% of the case are ISL. And you can see those ISL, 80%, around 80% are the instant ISL. That means the ISL is not outside the stent. Then in this sort of ISL, you treat with DCB, that was the expected outcome. It was very reasonable and acceptable. Overall, it's around 7% or 9% target vessel revascularization or target lesion revascularization. So the concept in choosing of DCB is give, maybe I just make a joke, a funny thing, just like the marriage. What is the key to make a successful marriage in human? The answer is love. So what is the key to make a successful marriage between the old style balloon angioplasty plus the new drug-eluting technology? In fact, it's the excipients that help to buy the drug to the balloon and help to buy the drug to your patient is the excipient. Good excipient is essential. Now, I show you the DCB, the one give worse outcome than Texas is because they don't have good excipient, and that's why it gives this outcome. And not every DCB, their excipient are the same. For example, Pandora Lux is BTHC is highly lipophilic and not soluble in liquid. Others, for example, Impact Vesicum is used urea, and there are many other types. So which one is true love? Which one is the best one? In fact, there's no randomized trial, and I cannot comment. And they have different nature, and you can think maybe different operator have different feel, different understanding, and you choose a one that you think that is most practical. Of course, we are looking for a randomized trial on different DCB, different excipients. So that are the in general for DS, I think more or less every DS is the same. Some may prefer thin strap, but there's no evidence at all. So we have discussed in general the ISL classification, the choice between DCB and DS, and then we're going to the second question: how to settle the mechanical problem in ISL. The first thing is under expansion. Many of times due to calcium, heavily calcified, and then ISR. For those cases, IFAS or OCT is good, but the most important thing is if you can pass the IFAS in, many of the time IFAS cannot pass. And this situation, don't forget stent boost. In fact, it's very good. You just push the IFAS or small balloon over there and then do a stent boost. Then you can overview the whole picture of the stent and know what are the problem. Then in this sort of situation, most of the time, I will use motivation plus short wave. And remember, the short wave balloon size must use 1:1. I just give you some example. Boy, EF, old gentleman, ISR over outside AAD, and then this was the angiogram, heavily calcified ISR, IS cannot go, and outside also heavily calcified ISR. And then the treatment is to first motivation because IFAS cannot pass, and the IFAS review and still heavily calcified. We found circumferential calcium despite motivation, and you can see with shortwave it's not expandable. And then after repeat shortwave, and it was well expanded. And same for RSA, water shortwave, well prepare everything and then stand it. And that was the final result. Once you settle all the mechanical problem, usually the prognosis are good. So, how about stent fracture? My experience is that usually stent boost is better in this situation, and almost always you have to stand it. And you need to use high pressure ballooning to smoothen everything inside the corner. I give you some example. This is a young gentleman. He has 6 PCI done before in another hospital and come from the 7th PCI. Why the patient have repeated ISL is stent fracture. Yeah. Can you see? Can you appreciate it mid outside the stent fracture? If you use stent boost, you can see it very, very clearly. The tips and tricks for this situation is the wiring. You need to wire carefully because they just displace the two stent, proximal part and distal part. They are displaced, so the lumen is very small and avoid to wire under stent strap, and sometimes it's unavoidable. But anyway, be careful on wiring. And then after that, you balloon well prepared, and then give another stand and high pressure. So what is your stand of choice? That's important. There's no evidence for this sort of situation for stent fracture. I don't know. I really don't know. At that time, it's few years ago, I will use biofilm because it's stainless steel and it's quite thick. And nowadays, maybe I will consider Megatron. I'm not sure. Maybe we can discuss and share your experience. But my experience that you always need to have very high pressure ballooning, make sure that everything was smooth after the stenting. and that was the final angiogram. The patient did not come back to find me in the past 5 years. I hope it was successful, or maybe he go to visit another doctor. I'm not sure. But he do not have any repeat revascularization or readmission for 5 years. So how to settle calcium nodule? That is also a very, very important topic. Many of the time of the ISL is you miss the calcium nodule and then you stand and then cause ISL. For this sort of situation, IFAS or OCT are very important. Stent boost can help, but it's not. It will not be as precise as IFAS or OCT to tell you. For calcium nodule, the recommendation is rotabation. You need big burr. Most of the time, you need 2O burr and plus short wave. Give you one example. The patient had PCI to RSA 6 months ago and then admit for recurrent ACSC. Here, you can see there's stenosis over here. Yeah. Why this will happen? We do the IFAS and then we found out what's going on. You see, there's a calcium nodule, very big nodule, causes the malposition. And after the nodule, and then very significant ISL, big calcium nodule. So in this sort of situation, imagine if you don't use IFAS, I just give you this picture. Can you find that there's a calcium nodule? No, not possible. That's why many of the time you need intravascular imaging. Without it, you can never identify. You don't identify, so you don't think IFAS is necessary. Then for this case, we use a 2O burr and and you can see that already remove lots of things and some part of the sand struct. And after that, we did the IFAS outcome is still not good, and we put one short wave 1-to-1. And for this situation, for calcium nodule, always remember, avoid very, very high pressure, for example, OPN up to 30, 40, something, because you cannot destroy the calcium nodule. You just expel it, expand it out, push it out, and then many of the time will cause rupture if you use very high pressure. So you need to consider something to remove it, or a short wave to crack it. But the outcome, whether the short wave is useful, many of the time is by luck. Most of the time is not very useful. Maybe 50 to 60% of chance will have some improvement, but not always. Then we put another stent. That was the final call. You see, there's much more improvement, but in IFAS still has some problem, but that is the best we can do. We already use 2O burr and short wave. So that is the summary of my talk. I try to share another definition in ISL and share my view on how to choose DCB and DES in ISL, and give example and tips and tricks how to manage underexpansion, stent fracture, and calcium nodule. And thank you very much. That's my presentation. Thanks.
Hi, Dr. Lam. Thank you so much for such that excellent talk and sharing your experiences and your insights. I just had a question. You know, there tends to be in the literature two separations, DCB or DES. There are so many instances, though, when you use rotablated, etc., where, or IVL or cutting a scoring balloon, where you wonder that whether we should be combining those treatments. So rotablate and then DCB. Versus just, you know, rotablation by itself. What are your thoughts about combining treatment? Because as you can imagine, after you rotablate or after you perform laser, etc., you leave a lot of raw tissue that you've just cut through. So maybe the way to pacify that raw tissue is to also add DCB on top of your other treatments.
Yeah, thank you, Dr. Guan, for your questions. I think that's excellent. I also want to share my concept. Nowadays, I found rotabation is not enough at all. You must rotabate and then plus something, either water cut, water OPN, water NC, water DCB, or water short wave. Many of time, if you when you do a lot of intravascular imaging, you find that just after water, you expect you may remove a lot, but in intravascular imaging, you found that you did not remove a lot of calcium or plaque, and maybe you just crack it. So it's better after the water patient, you still do more maneuver, and then I guess that may be more likely you have a better outcome. However, all this study, as far as I know, there are no such study. But in my experience nowadays, based on the routine, I do lots of intravascular imaging, and based on those findings, I found that just water patient is not enough. How about maybe Dr. Fahim? What is your point of view on this aspect?
Yeah, I agree with Lam. Excellent talk. Both Kwan your talk and Lam, really outstanding talks. I mean, I agree that I think that when you're talking about in-stent restenosis, you really are looking at the need to use multiple devices and sort of assume that devices can sometimes work synergistically. So whether it's IVL and ablation or whether it's high pressure dilatation and IVL. I just want to make one point that regarding DCB, I mean, in our practice, we use it quite a lot. And one of the things we found is that with DCB, you have to make sure you don't have any geographic miss when you deploy it in a vessel that was stented and you've just dilated it. So in other words, you need to make sure that the DCB crosses the stent edges, and make sure that the whole lesion length is very well covered, because that is geographic miss is one of the modes of failure of DCB in this situation. I just thought I wanted to ask both of you one question is that it's not infrequent that you see stents that were very well deployed in the initial intervention, and then you come back there, the stent has sort of shrunk right in one particular spot. I wanted to pick your brains on the idea of stent recoil. How often do you think it happens in real life, and how do you approach it?
I think stent recoil, it really depends on the initial deployment and the setting in which it was deployed. Obviously, a poorly prepared calcified lesion in the past, there's definitely higher rates of recoil. In-stent restenosis that's not adequately prepared, higher rates of recoil. You're definitely entering a slippery slope once you get recoil. Well, the question is really, what is the mechanism of recoil? Is it from vasomotion with the heart beating, similar to a subform of the forces that lead to strut fracture? I think in general, when I see recoil, I start to understand that, it's problematic and we're going to be back here very likely. I tend to use the highest radial force possible stents with thicker struts. I don't go for thin strut stents if I'm treating areas of recoil in the past. And I almost always end up having to re-stent that area, after prepping it with ultra-high balloon inflations. What about you, Dr. Lam Ho?
Thank you. I think stent recoil, there's something very rare. I don't have much experience on that. In my limited experience, most of time I see on IFAS or on OCT or stent boost, something that is happen when the stent expansion limit is, for example, 3.5. The previous operator stand from AD to left main and expand to 4.0, 4.25 something. Over stress of the stand and then destroy the stand struct architecture. And many of the time is this mechanism and cause the stand recoil. Otherwise, I did not see a lot. For all this situation, my treatment will be the same as stent fracture. I always put another stent with good expansion limit and then put on it and then high pressure. That is my usual approach. Because I don't have much experience on this aspect.
Okay, thank you very much. we're going to wrap up the session here.
Okay, thank you very much for our professor and doctor from Hong Kong, from United States and Singapore. I have some wrap up by Vietnamese. Đây là một cái phiên rất là hay về tái hẹp trong stent động mạch vành. Thì chúng ta đã biết là gì? Là khi mà dòng chảy nó thành lớp ấy, thì cái khả năng bị tái hẹp nó sẽ ít đi. Còn so với cái dòng chảy mà nó bị rối, và OCT và cũng như IVUS vẫn là một trong hai trong các cái biện pháp chẩn đoán ảnh nội mạch để đánh giá tái hẹp. Và sau khi mà đánh giá tái hẹp để đánh giá xem là stent có nở tốt không, áp sát không, có bị dissection không, thì sẽ có những cái strategy để chúng ta có thể can thiệp cái tái hẹp. Và ưu tiên là gì? Chúng ta sẽ dùng bóng hoặc là dùng bóng phủ thuốc. Còn nếu trong trường hợp đặc biệt thì với stent tái hẹp ở trong lòng stent thì chúng ta dùng bóng phủ thuốc. Còn nếu tái hẹp ở rìa stent chúng ta có thể là stent. Và cái can thiệp đó có thể đặt ra sau khi mà chúng ta sử dụng các biện pháp chuẩn bị tổn thương. Thì một lần nữa thì cảm ơn các giáo sư, bác sĩ tham dự cái buổi hội thảo ngày hôm nay, và cảm ơn tất cả các khán thính giả đã đến chương trình. Xin cảm ơn tất cả.
Science, no matter how advanced, is only as meaningful as the lives it transforms. At Boston Scientific, more than 30 years of meaningful innovation has saved and improved millions of lives through pioneering treatments for coronary and peripheral artery diseases, digestive diseases, urinary and women's health disorders, and abnormal heart rhythm. Life.
For 3 decades, we have dedicated ourselves to meet the health needs of every person on our planet. Today, as the world evolves, we see that the human-health relationship is more connected and more conscious. We see newer and different health needs that require more science. Hetero is transforming with a renewed focus on people above all else, with a new identity. To create a bigger impact, shaped by warmth and passion, and our commitment to science with a renewed purpose of inspiring human belief in a healthier world. Say hello to a healthier world. Say hello to the new hetero.
Dapagliflozin đã có mặt và đồng hành cùng bác sĩ và bệnh nhân Việt Nam từ năm 2016. Là ức chế SGLT2 đầu tiên được phê duyệt chỉ định cho bệnh nhân đái tháo đường tuyếp 2. Chặng đường nghiên cứu và phát triển được tiếp bước. Đến năm 2018, thử nghiệm Digletimine 58 được công bố. Dapagliflozin cho thấy lợi ích bảo vệ tim thần cho bệnh nhân đái tháo đường tuyếp 2, dù đã có bệnh tim mạch hay chỉ mới có các yếu tố nguy cơ. Cũng từ thử nghiệm Digletimine 58, các cơ chế mang lại lợi ích trên suy tim của Dapagliflozin dần được làm rõ như tăng thải natri niệu, giảm tiền tải, hậu tải, giảm áp lực lọc cầu thận, bảo vệ thận, cải thiện chuyển hóa tại tim, giảm phù thể tích khoang kẽ. Đến năm 2019,
hello everyone. May I start the session by inviting Dr. Natawut Wongpraparut to deliver his presentation.
Hello, thank you very much. Did you hear me well?
Yes.
Okay, good. Let me get some slides. Do you see my slide?
Yes, Dr. Natawut.
Okay, thank you. Thank you for invitation. And good afternoon, ladies and gentlemen. My name is Dr. Natawut Wongpraparut. It's my pleasure to be here to give a talk on the tip and trick for bicuspid aortic stenosis. I have no disclosure. So I think the bicuspid aortic valve have many challenges to perform the TAVI. Most of the time, it has been excluded from the clinical trial. There are different morphology of a valve from the bicuspid compared to tricuspid. They have the heterogeneous of the cusp and sinus morphology. Often the time they have the mismatch between the leaflet and annulus orifice, and compared to the patient with tricuspid aortic valve, the bicuspid have more calcium, and many times they have asymmetrical calcium distribution, and this could lead to complication. And many times also involved with the orthopathy, with aortic root. So if you look at the current guideline statement from ACC in 2021, in the patient with bicuspid aortic stenosis, they recommend for favor for surgical aortic valve, and especially in the young patient and the patient with aortic root dilatation. So if you have the bicuspid with the aortic sinus or ascending aortic diameter more than 5.5, is class 1 indication for valve replacement and ascending aorta repair. And if you have above 5.5 to 5.0 to 5.5 in ascending aorta diameter, it's class 2A. This is the prior trial in the bicuspid compared to tricuspid aortic valve in performing TAVI. You can see in early generation of the device, the bicuspid actually have, compared to tricuspid, have more likely to convert to surgery, have more likely to have the second valve implantation, and more likely to have paravalvular leakage, and less chance of success. But with the new technology and more understanding of the bicuspid aortic stenosis, with the new generation of device, I think you have the comparable results compared to the tricuspid aortic stenosis. There's still a little bit more of the paravalvular leak compared to tricuspid aortic stenosis when we perform the TAVI. So let me further look in this trial that recently been published in the circulation that took the data from the TC transcatheter valve therapy registry. Involved almost 200,000 patients, compared to patient with bicuspid, which involved about 500,000 compared to tricuspid, over 160,000 patients. As you can see, the age of the patient is younger, and you can see with the new generation of the device, the success rate is as good as the tricuspid. But I think need of a second valve and post-TAVI aortic regurgitation, moderate to severe, also a little bit higher. So I think if we want to do the bicuspid, we give you a 5 tip and trick. I think it's durable, but I think you need to first understand the type of bicuspid. Not all the bicuspid is the same. They have the different type, different classification, and they have on this type and classification, they have different related pathology. The most common classification we use and is called Siewert, ischemic bicuspid aortic valve. And this classification divided by the number of the raphe of the patient have. If the patient have no raphe, we call type 0, and this involves about 12% of the patient. On another end, if you have two raphe, which is sometimes called unicusp, is called type 2. In the patient with type 1 raphe, it's most common. It can be fused between right or left, right and none and left. And this is a common presentation. And this also includes the patient with tricuspid, with functional bicuspid, with a fuse between raphe as well. So you can see this is the type 0, no raphe at all. This is about 10% of the patient. And with the 1 raphe, it's very in Asian, very common to have the fusion between left cusp and right cusp, and followed by right and none and left and none cusp. Type 2 raphe is sometimes called unicusp. I think this is very difficult thing. I think this should be reserved for surgical aortic valve. And this type can be related to arthropathy. As you know, that bicuspid can sometimes involve with the aortic root dilatation. So if you have the fuse between the left and right cusp, you will have type 1 dilatation of ascending aorta. Compared to the right and non-cusp fusion, we have the dilatation more to aortic arc. Another classification has been proposed, even though the Siewert classification is commonly known, but I think it's GW classification is more practical in terms of how that bicuspid will be impact on the TAVI expansion and how the TAVI will be sit into that anatomy. So this is a classification just separate the patient, have bicommissure with or without raphe, and tricommissure that is similar to the tricuspid aortic stenosis. And I can show you here, this is example. So you can see this one is to bicommissure and no raphe at all. So this is will be a GW bicommissure with non-raphe or type 0 in the Siewert classification. Another, this one is bicommissure, these two, one with calcified raphe, like this one, and one without calcified raphe. And this one in the Siewert will be type 1 RL and RN. And the tricommissure is a mix similar to the tricuspid valve. So I think, so this one will give more, this classification will be give more understanding how the TAVI will be impact on the anatomy that the patient has. So it's more practical in terms of the prediction and in terms of valve sizings and in terms of the position of the valve. And the next step, once you know the different type and different classification of bicuspid, is not all the same. So the next, I think you need to know what is the predictor of the poor outcome in the TAVI in bicuspid. A very nice study from Dr. Yun and his group published in JACC in 2020. He looked, this is based on the GW classification with tricusp or tricommissure or bicommissure with raphe, with calcified raphe, with no calcified raphe or no raphe at all. And you can see if we separate the patient in 3 groups, that depend on that one end will be have no calcified raphe, no excess leaflet calcification. The risk of mortality, risk of complication, risk of annular rupture is very low. It's only 5.9%. Compared to the other end, if the patient have very excessive calcium or have calcified raphe, I think this is the one of the predictor of the poor outcome, similar to this. So you could have the all-cause mortality go up to 13% at 1 year and 25% at 2 years. And in the patient have either or, will be intermediate group. So with this classification, with this understanding, you know what bicuspid is favorable for TAVI, with what bicuspid you could do, but you need to take a lot of caution in order to do it. This is another study from Cedars-Sinai, site-initiated multi-registry, similar to the study from Yun that separate the patient with bicuspid according to their classification to low risk, intermediate risk, and high risk. depend on the severe calcified and also with the calcium on the leaflet. So basically, if you have a lot of calcium in the leaflet, if you have calcified raphe, the risk of complications is much higher compared to patient without. So once you understand classification, understand what the predictor according to classification, the next doing bicuspid, TAVI for bicuspid, you need to understand more comprehensive understanding of imaging role. I think this is the key for success, because if you good analysis on the imaging before, you could have the good planning when you go in and do it, and also can help you predict and avoid complications that might be occur. So in bicuspid, in usually in tricuspid, the narrowest part will be at annulus part, where you deploy the valve. But in bicuspid, sometimes leaflet is length is higher, and sometimes many times actually the smallest part will be at the raphe ring. So will be at the intercommissural, a little bit higher in supraannular part beyond annular plane. So I think you need to know this. And when you measure for sizings, one, you do the sizing, virtual basal link measure, similar to the tricuspid, that you look at the annulus and measure the area and decide of the size of the valve you can use. But in the bicuspid, you need to scan above to supraannular area at insistently and look at the smallest part, and most of the time will be at the tip of intercommission. And you need to measure on this part in different method. So you do understand what the character and what is the pattern of this. So on the Bawat registry, they have separate the patient based on the sizings of annulus and sizing of intercommissure to be a tube. So that means that if both of them is similar sizings. If they have flare, that means that the annulus is smaller than the intercommissural area. So I think when you sizing this, you go to for smallest part, that will be size of the valve will be at the annulus plane. And if you have the taper type, that annulus is bigger than intercommissural area. So I think you based on the smallest part, that will be on the ICD part. So with this understanding, you know what pattern of the mismatch, which is often occur in the patient with the bicuspid. So you know how to sizing the valve appropriately. And if sometime when you have the bicommissure with raphe, like with calcified raphe like this, that it can have a lot of increased risk of complication. The other way to use is called V method. So you do go to the supraannular plane at end systole and look at the tip of ICD where the leaflet opening, and look at the measurement. So you get the maximum measurement at ICD and another measurement at the tip of that base of this calcium to another intercommissure, and you average these two, sum up these two and divide by 2. You have average area of the sizings of the IC at the raphe plane. And then you go to the basal plane and measure the size similar to you do in the tricuspid. And if the size is similar, it's tube type, so you can use you can use this size either of them. But if anyone is smaller, you should go for the smallest size for valve sizings. And another method is called circle method, and this is so you know the area, and then if you think maybe 23 or 26, then you put the virtual valve and put in the 3, 6, 9 or annulus 4 and 8, and see how this virtual valve will be interact with the calciums with anatomy that around the each plane. Many times when we do bicuspid, apart from this accurate measurement from Wave method, from circle method, they have a lot of role for pre-balloon simultaneous contrast injection, or we call balloon testing. So balloon testing actually will help for facilitate traffic crossing. Many times in bicuspid, difficult crossing anatomy is deformed. And you can also, when you do balloon testing, you can test for rapid resistance and predict how the TAV will be expanded. And you help to define. Sometimes if you measure, you're not sure you're going to use 23 or 26. If you put 23 and have a lot of leakage, you know that you need to go bigger. If you put 26 and it's maybe cause some obstruction or some, so you know, so it helps you sizing of the valve more accurately. And you can foresee the risk of the residual leakage, a risk of re-obstruction by use of balloon testing in this bicuspid valve. So once you have everything, you put it all together. You need to look at the patient. If patient very young, and you cannot, even though you can do it, but you may leave the patient with a lot of paravalvular leak that will live long. I think they should go for surgery. Or if the patient have ascending aorta very big, I think surgery is an option. But if there is not any of them, if they have intermediate risk in the old patient, anatomy is fit through the multi-level CT analysis that you look and you think you can do it, I think you can go for it. So you should consider pre-balloon dilatation. And many times I always do silver protection because a lot of time with bicuspid, they have a lot of calciums. So they quickly get stroke. So I will do silver protection in the bicuspid and also valve with valve. And this is how the step putting together. You look at the BAV morphology. This is bicommissure or tricommissure with or without raphe. And if have the raphe, is raphe calcium calcified or not? You look at the sizing and the last sizing of ICD, and then you decide how to size the prosthesis. Then you do the balloon testing technique during the procedure to help to see how to interact with the raphe and how its valve will be fit, and then you deploy the valve. And if you still have residual gradient or you have the residual of the AR post-dilatation could be considered, but you need to take a risk-benefit between rupture and leak of paravalvular leak. But I think when you have the good CT analysis, I think you have plan A, B, C in your mind before you can go into the lab. So I give you a couple examples of the case bicuspid that we do. So we have the 80 years old with 18% of the EF, mean gradient of 40, valve area of 0.5. So we do the complete analysis measurement. Patients very high risk for in our heart team to do surgery because of the EF. And then this assessment is fit for 23 valve. So this is a circle method that we use on this patient. And you can see this is bicommissure without raphe or type 0 on the silver classification. So we did the balloon testing and look for how the valve, as you can see, the valve was reoriented, but once it's balloon dilated, it's reorientation. And then with this information, we know that valve 23 is a good fit. And then so we deploy the valve. You can see how the valve in this bicuspid will shift and then slowly turn. So when you deploy, you need to go very slow. And this is the final result. You can see very good results. Position 80-20, no paravalvular leak. Another case, more complex with the type 1 with calcified raphe or GW classification with bicommissure with calcified raphe. So this is the risk of the annular rupture. So again, with the CT analysis, with the measurement, we see that at the annulus plane, there actually not much calcium over there. So we know that it could be safe to do it. And again, the same step, we do the balloon dilatation and once and see contrast injection, and you can see the valve based on this. I think 23 valve is good, and then we deploy. We look at the leaflet and make sure that the this cover tip of the leaflet, and this is the final result. It's no parabola leak. So in conclusion, I think many challenging in the TAVI in bicuspid aortic stenosis. If you have the case with very young patient and patient with dilatation of ascending aorta more than 5.5, surgical aortic valve replacement is a gold standard. Outcome have been improved with new generation device, but I think you need to get the heart team for case selection, and you need to understand the type and classification of bicuspid aortic valve. You need to know the predictor of the poor outcome and use CT analysis to help for sizing, positioning, and deployment. And many times pre-BAV with some injection will help to guide you, and you need to comprehensive evaluation for patient selection and research plan. Thank you very much.
Thank you, Dr. Nathan, for your very practical, instructive, and up-to-date information. I have a short question. According to you, between the balloon expandable valve and the self-expandable valve, in case of bicuspid, which one seems to you to be safer or better?
We don't have much experience with the self-expandable. I think in our lab we have we use majority of the SAPIEN valve, and I think most of the time it can do very well. So with the S3, you have the skirt, so you prevent parabola leakage. So I think that majority of the case that we use. We also have the cortical in our lab, but I think with the calciums, I feel more strange. I mean, I need more resistance with the balloon expandable to help, but certainly, but in some case, if a lot of calciums and you think at least of annular rupture, so expandable may be a choice, but I think most of the time we could do it with a balloon expandable.
Thank you so much, Dr. Nathan. We move on to the next speaker.
Vâng, tiếp theo sẽ đến bài chị Mỹ. Okay, thank you so much. So the next section will be presented by Dr. Jonathan App from National Heart Center Singapore about how to reduce AV block after TAVI. So Jonathan, are you here?
Yeah, can you hear me?
Yeah, very clear. Go ahead, thanks. Link is here. Okay, thank you.
Okay.
Good to see you.
Thank you. So it's thank you for inviting me to give this talk. Today I'm going to talk a little bit about how to reduce AV block in TAVI. I'm Jonathan from National Heart Center Singapore, and so this is a quick outline of what I'm going to go through today. I'm going to go through a quick introduction. We'll talk a little bit about the impact of AV block as well as PPMs, and then I'll go through some techniques and algorithms on how to reduce pacemaker insertions. And then if we have some time, I would like to share some cases. So we all know that with the low-risk trials, TAVI is pretty good in the low-risk cohort, equivalent in the Evolute low-risk trial to surgery, and even superior in the SAPIEN 3 trial, the partner 3 trial with the SAPIEN valve. And because of this, the guidelines have actually been changed recently to recommend TAVI as a first-line class 1 indication in those 65 to 80 years old. And with this, we need to think about some things, like in the past, when we did TAVI in high-risk patients, if they needed pacemakers, they had left bundle branch blocks and all that, we said, hey, maybe that's okay. But as we come to the younger folks, that we are doing TAVI in, AV blocks as well as pacemaker insertions become a lot more of a deal. So these are some issues that we encounter when we do TAVI in the low-risk patient, AV blocks and pacemaker considerations, and some ways to overcome this is using the cast overlap technique, coronary access, using some commercial alignment techniques, we can lower this risk, and this will be talked in the next lecture, and also some thoughts about durability and future valve-in-valve. My focus today is on AV blocks as well as pacemaker insertions, and so I would like everyone to understand a little bit about the anatomy of the AV conduction system in the heart. As you know, the membranous septum is where you can see my mouse is, and behind the membranous septum lies the AV bundle, And the AV bundle splits into the left and the right bundle branch. And the left bundle branch actually causes just inferior to the junction between the right coronary cusp as well as the non-coronary cusp. So there are many studies that looked at the predictors of pacemaker insertions after TAVI. This is a summary of them. And basically, if you look at those in yellow, these are existing ECG abnormalities on the baseline that could increase your risk of getting a pacemaker after TAVI. So things like pre-existing right bundle branch, left bundle branch block, pre-existing first degree block. Some procedural balloon-related stuff, if you have some balloon pre-dilatation or post-dilatation, it increases your risk. Some things related to the valve, if your valve is oversized, if you're using a self-expandable valve, or if you implant a low, all these increase your risk of getting a pacemaker. And lastly, if you have calcifications at your landing zone or your LVOT, that will also increase your risk of pacemaker. I want to highlight two very important factors, and this has come up in the recent times. One is the length of the membranous septum. If you do a CT, which most of us do for our TAVI, you can actually measure the length of the membranous septum. You should choose a phase whereby both the right side and the left side lights up somewhat, and then in somewhat of the four-chamber view, you can kind of measure the length of the membranous septum, where my mouse is. And many studies have shown that, the shorter the length of your membranous septum, the higher the risk of pacemaker insertion. If you look at these two similar cases, the implantation depth was similar, 8 mm and 8 mm each, but the membranous septum in the first case was 3 millimeters, and the membranous septum in the next was 13 millimeters. One had right bundle branch block, left bundle branch block after the procedure, and one had a narrow QRS. And studies have shown that the cutoff, less than 3, you are very high risk of pacemaker. 3 to 6, you're intermediate risk, and if your membranous septum is more than 6 millimeters, you're at much lower risk of pacemaker. So that can kind of help you when you're planning, how high you want to implant for that case. The second thing that we all know, the types of valve actually impact the rate, pacemaker rate. Self-expandable valves have a slightly higher risk of pacemaker insertions, ranging between 10 to 15%. This has come down somewhat in the recent years with the cusp overlap technique, whereas balloon expandable valves range from about 5 to 8% pacemaker rate. So, if you develop a new left bundle branch block after TAVI, is it bad? So these are a series of studies that have looked at the impact of a new left bundle branch block after TAVI. If you can look at where my mouse is, of note, the length of follow-up is between 1 to 3 years only. If you look at the rate of all-cause mortality and cardiovascular mortality, it's very mixed. Some studies show increased mortality, some studies show no association. But there's quite consistent impact on LVEF that the LVEF tends to drop if you develop a new left bundle branch block. And as I said, the follow-up is only up to about 1, 2 to 3 years. As we implant TAVIs in the lower risk younger patients, we are not sure of this impact in the longer run, 5, 10, 15 years. How about the impact of, this is pacemaker. So if you need a pacemaker, you put it in after TAVI, what's the impact on overall mortality? As you can see, there are once again many studies, a lot of them showing some negative impact on mortality, and some meta-analysis combining all these studies show overall significant impact on mortality with pacemaker insertions. The impact on cardiovascular mortality is a bit more mixed, and there's a bit of equipoise here. So how do we manage a patient who develops conduction abnormalities after a pacemaker? This is from the 2019 guidelines that were published in JACC. So I'll just go through them very, very briefly. So number one, if you have no ECG changes and your baseline ECG was normal, so you do a 12-lead ECG, after the procedure. If there are no ECG changes, you can remove the temporary pacing wire immediately at the end of the procedure and just place the patient on telemetry overnight. And if nothing was noted on telemetry, you can go home the next day. So pretty straightforward. If you have no ECG changes, but you have an existing right bundle branch block, you can consider keeping the pacemaker in, the temporary pacemaker in overnight. And if nothing happens, you can take it out the next day, and they recommend actually monitoring for an additional day on telemetry. So a total of 2 days on telemetry. Anytime we develop a complete heart block or higher grade AV block, you should go for a pacemaker. If you have existing right bundle branch block, but some minor changes, like maybe a bit broadening of your QRS, increase in your PR duration, but no complete heart block yet, they recommend you still keep the pacemaker overnight and then you observe. If the changes resolve, you can take off the pacemaker and then continue to monitor for one more day over here. If the changes get worse, but not yet complete heart block, they recommend you keep the temporary pacing wire for another 1 day and observe what happens. So this is interesting. If you develop a new left bundle branch block, what should you do? So you should keep the pacemaker overnight and monitor. If the left bundle branch block resolves, you can take away the temporary pacing wire and then monitor on telemetry for yet another day. If the left bundle branch block remains, this is what they recommend. If your left bundle branch block the QRS is less than 150 milliseconds and your PR is less than 240, you can still go home after 2 days of monitoring if there's nothing serious. But in those, the QRS is very wide, or the PR is very long, then you may want to consider longer duration of monitoring or invasive electrophysiology study or even a pacemaker. So the jury is out there on this. And of course, if you have a high-grade AV block that doesn't resolve, you should definitely put in a pacemaker. I'm going to skip past this in the interest of time. So I just want to mention this study that many people have talked about from the Danish group that was published in 2018. This is the need or whether you should keep your temporary pacing wire in after the procedure. So this is a very simplified algorithm. So they say, do a 12-lead ECG. If your patient is in sinus rhythm and your QRS is not broad, it's less than 150 milliseconds, or if you're in atrial fibrillation, you're less than 140 milliseconds, it is very safe to take out the temporary pacing wire. All right, so this is a very brief summary of a simplified algorithm on whether to keep the pacing wire in or not after the procedure. So that is how to manage a conduction block, after the TAVI procedure. But I think what we are most interested in is how do we actually reduce this risk of needing a pacemaker and reducing conduction block. So there are some strategies that we can employ during the procedure itself. Number one is the task overlap view, and number two is aiming a slightly higher implant. I'm going to talk about two examples with the balloon expandable valve as well as the self-expandable valve. So as we know, this is the recommended sapien implantation depth. If you look at the bottom diagram, in the first trials that are done more than a decade ago, they recommend using the balloon marker slightly below the annulus. So the top of the balloon marker slightly below the annulus. With more data, they have actually recommended this. So the balloon marker, either the middle right at the annulus, but the ideal is, the bottom of the balloon marker at the annulus. So that is the recommended deployment for the sapien valve. But many of us who use the balloon expandable valve knows that, the balloon is, in relation to the valve, can vary. Sometimes you dial it in a bit too much, you dial it in a bit too little, or you release the tension. The balloon may not be centered exactly on the valve. And so with that, people have talked in recent last two years or so, people have talked about this loosen line technique, whereby your eyes no longer focus on the balloon marker, but rather you focus on the loosen line. If you follow my mouse here, this is the sapien valve. You can see this loosen line here. All right, so in recent times, more and more centers are actually switching to positioning the sapien valve based on the loosen line. So let me show you this example that was published in Circulation. So as you can see here, they deploy in the cast overlap view for the sapien valve in this case. So you have the balloon marker right at where the annulus is. Okay, just above, as recommended. And after inflation, this is where you end up. You have a depth of about 4.7 millimeters, so that's about 80-20. So this group and several other groups are suggesting a higher implant to reduce pacemaker rate. So implant at almost 90-10 or 0-100. So what they recommend is if you see this loosen line here, they recommend putting the loosen line right where the annulus is. You inflate it, and then you will get almost a 0-100. Really nice and reduce your pacemaker rates. Of note, if you overfill your valve and your valve shortens more, you really need to aim lower, and if not, your valve may embolize. So over in National Heart Center, we have also switched to doing the Lucerne line. We feel that, the method described before, placing the Lucerne line right at the annulus, is a bit too risky. You may avoid pacemaker, but you may have a higher rate of valve embolization, especially if you overfill your valve. So right now, currently what we do for most cases, if you see this case one, we aim for the Lucerne line slightly below the annulus. So that gives us a lot more leeway. And as you can see, this deployment here is almost 85-15, 90-10. So really nice, aiming this Lucerne line where my mouse is, just below the annulus. That's case example number 1. Let me show you the deployment of another valve. As you can see here, this is the Lucerne line where my mouse is. We are about 1 Lucerne line below the annulus. And when we deploy, this is our final result. So right now, most of the time, we position based on the Lucerne line and no longer looking at the dot. So a little bit about the cast overlap view, as I mentioned earlier. So we know that in the coplanar view, if you look at example B, the LVOT is foreshortened. So, you can see that the conduction system is very close to the cast. In the cast overlap view, though, you elongate the LVOT, so you have a better appreciation of depth of the conduction system in relation to your cast. So studies have shown, if you look at the double S curve, the double S meaning one curve in relation to the annulus and one curve in relation to your device, the double S curves meet somewhere in the RAO caudal view. So if you deploy in the RAO caudal view, there's a high chance of your device not having any parallax, and yet and your annulus also not having any parallax. So in the Evolute low risk trial, they found that if you look on the y-axis is the rate of pacemakers, and on x-axis is the number of subjects that were implanted. There are certain sites where they implant very low, and they have a lot of pacemaker rates. And if you look at this outlier here, this red dot here, they recruited almost 70 subjects, and they had an extremely low, less than 5% pacemaker rate. And so the question arose like, hey, what was happening at this site that they were so good at avoiding pacemaker? And that was the Gada's Hammel's site. And so Gada Hammel was the guy who first introduced the concept of the deployment in the cast overlap view. So he actually extended this technique to several countries in Latin America, and this is using the Evolute valve. You can see that, even in these new centers using this cast overlap view, their pacemaker rate was about 6%, almost equivalent to that of the balloon expandable valve. And prior to that, the self-expandable valves, we're looking at pacemaker rates of about 10 to 15%. So what is the cast overlap view? Maybe I'll just briefly go through an example. We all know for the Evolute valve, we insert at 3 o'clock to try to optimize commercial alignment. So they recommend using a stiff wire so that there's less orientation of your valve. Then you deploy actually in the cast overlap view, starting high, where your mid level of the pigtail, and as you unsheath the valve, your valve will dive in. And so this reduces trauma to the conduction system. Okay, so next step, you start pacing at about 120 beats per minute. Some people pace higher to reduce the movement of the valve. And then you deploy first in the cast overlap view to the point of no return. Okay, next you will stop pacing, and then you take a shot in the cast overlap view, which is here. You can see that the depth is pretty good on the non-cast, almost just 1 or 2 millimeters. And then you turn your II over to the LAO view. All right, so that, and then you proceed the rest of the deployment in the LAO view. Yeah, and the rest of the deployment is as per standard. You go really slow, give some time for tension to be relieved from the system. See, it's really slow deployment. And then these are some considerations. If your depth is less than 1 millimeter at the NCC on the cast overlap view, you may want to recapture because you may embolize, or if you are too deep, more than 5, you may want to recapture and reposition. Okay, I just want to show just 2 quick cases. I have had a patient who's 89 years old. His diameter of his valve was about 25 millimeters. So he opted to use a 29 evolute. So you can see here, this is the cast overlap view. This is where my mouse is, that's the non. And then on the other side is the left and right cast. So we deploy in the cast overlap view. Something to note, you can see the head marker, it's center front. So very likely we are going to more likely to achieve commercial alignment. So center front head marker, we deploy in the cast overlap view. And this point here in the non-coronary cast, you can see we are about 1-2 mm below. So that's a perfect depth. And we switch over to the LAO to complete the deployment. This is the final shot. So you can see really nice on the non, just maybe -1, and then we have adequate depth on the rest. Okay, this is just the last case I want to show. It's an 84-year-old lady. Once again, it's a bit of a smaller valve. Her average diameter was about 20, so we opted for 26 evolute. Once again, this is a picture of the cast overlap view at the RAO caudal for you to appreciate. So once again we deploy in the RAO caudal view. You can see that our head marker is also center front. By going in at 3 o'clock, we ensure higher chance of commercial alignment. This was our initial deployment. The valve dived a bit. You can see we're deep on the non and even deeper on the other side. Way too deep. We recaptured, positioned a bit higher, and this was a more acceptable depth. So we're almost -1 only on the non. And then this is the final. Okay, thank you.
Thank you, Jonathan, for amazing presentation. How to reduce the ppm in the TAVI procedures. So we have one question for you. You have a lot of tips and tricks to reduce the ppm when we do the TAVI. And in your experience, if you have a high risk of ppm, so which valves you choose for that patient, and with the sapient, which view over cast overlap or coplanar to deploy the valve? Thank you.
So I think based on the literature, like at the start, we know that the balloon expandable valves have much lower pacemaker rate as compared to the self-expandable valve. With the cast overlap view, this pacemaker rate in the self-expandable valve has actually dropped by quite a bit to almost equivalent to the balloon expandable valve. So I think both valves are equivalent. We have a little bit more of a preference, if the groins are big enough, for the balloon expandable valve, in a patient at high risk of a pacemaker, just because, it's a lot more controlled. So with regards to whether we deploy the balloon expandable valve in the cast overlap view or in the standard coplanar view, the initial IFU recommendations were to deploy in the coplanar view where you see all three casts aligned. There are some centers that have switched to deploying the sapient valve in the cast overlap view. At least for where we are now at National Heart Center, we have not gone to deploy the sapient valve in the cast overlap view. We've kind of prefer to keep it at the coplanar view, just because we are so used to it and we have been getting good results, and we don't see a huge point in changing at the moment. But for our balloon expandable valves, for our self-expandable valves, we do deploy in the cast overlap view.
So thank you, Jonathan. Thank you very much. So we move to the next speaker. Please welcome Dr. Yasuhiro Ichibori from Osaka Police Hospital, Osaka, Japan. Please welcome Dr. Yasuhiro.
Hello, everyone. Thank you for introducing me, and thank you for inviting me here today. So I would like to start my presentation. So I gave the conference my recorded presentation. So could you start my presentation? It's a great honor to be able to speak to you today. I'd like to thank many doctors in Vietnam for inviting me here. The title of my presentation is Risk Assessment and Prevention of Coronary Obstruction during TAVR. This is conflict of interest disclosure regarding this presentation. I would like to show you my nightmare case. The patient was 86 years old female. During past 6 months, she had been hospitalized for acute decompensated heart failure twice due to severe aortic stenosis and was referred to a hospital for TAVR. She lost her consciousness transiently at outpatient clinic, requiring emergent hospitalization. Her medication was as follows. She was a small Asian lady with 37 kilograms of weight. Her vital signs were stable. Blood tests revealed chronic kidney disease and elevation of B-type natriuretic peptide. Chest X-ray showed slight lung congestion and cardiomegaly. Transthoracic echocardiography showed very severe aortic stenosis with mean pressure gradient of 102 mm mercury and aortic valve area of 0.2 cm square and reduced LV ejection fraction. There was no stenosis on coronary angiography. On computed tomography, very severe calcification was observed on the aortic 3 cusps. Annulus diameter was around 22 mm. SOV sizes were balanced and around 29 mm. As you can see the left figure, when the transcatheter valve is deployed, bulky calcification on LCC will stand up and can cause LCA obstruction. As only SAPIEN XT was approved in Japan at that time, this patient was high risk not only for LCA obstruction but also for annulus rupture. Thus, her team strategy was surgical AVR. During hospitalization, she developed pneumonia and her heart failure deteriorated, requiring inotropes. After a week, she recovered from pneumonia using antibiotics, but her STS score showed 21% mortality for surgical AVR. We planned balloon valvuloplasty for her heart failure. After balloon valvuloplasty, her hemodynamics collapsed due to rapid pacing and moderate aortic regurgitation, and VA ECMO support was initiated. We decided to implant SAPIEN XT 23 mm. To protect LCA, guide wire and balloon were inserted into LAD. SAPIEN XT 23 mm was expanded very slowly. Very slow inflation. Because there was significant PVL, we performed post-dilation. This is also very slow. Angiography and IVAS revealed severe stenosis at LCA ostium due to the bulky leaflet calcium. 3.5 mm in diameter drug-eluting stent was implanted, followed by 4.5 mm post-dilation. LMT was optimally opened. On angiography, the valve was migrated into LV site but still staying on the annulus. There was contrast stain out of the aortic root and pericardial effusion was increasing, requiring drainage. On the next day, VA ECMO was weaned off. On POD2, patient was extubated. On POD9, chest X-ray revealed the valve was upside down and stuck on the LVOT. We also checked the valve on computed tomography. As shown in the left figure, Sapien XT is sitting under the native valve classification. There is still pericardial effusion. The patient refused open heart surgery and was discharged under stable condition, despite the valve inside left ventricle. It is reported that the incidence of coronary obstruction in native aortic valve is about 0.6%, and the risk is fourfold increase in TAVI-SAV. Coronary obstruction is a rare but life-threatening complication. The survival curve shows a mortality rate of 54% at 1-year follow-up. Anatomic factors, transcatheter heart valve-related factors, and surgical valve prosthesis-related factors are all associated with coronary obstruction. In anatomical factors, low coronary height, narrow sinus valsalva or sinus-tubular junction, and bulky calcium on the leaflet increase the risk of coronary obstruction. This study compared anatomical factors on computed tomography between Japanese and European. Asian patients have lower coronary height, narrower sinus valsalva, and smaller sinus-tubular junction. Thus, we need to carefully read CT images before the procedure and simulate how the native valve and calcification stand up when transcatheter heart valve is implanted. This is an example of coronary obstruction. The movie shows LCA obstruction after Sapien implantation. After estimating the risk, coronary protection with preventive guide wire insertion is the first step. As shown with the red bar, the absence of upfront coronary protection is related to worse outcome in patients with coronary obstruction. This study shows in very high-risk patients for coronary obstruction, preventive stenting across the coronary ostia is associated with a better outcome than the protection alone. Because there is a risk of delayed coronary obstruction in these high-risk patients, despite good coronary flow just after the implantation. Recently, good result of chimney stenting is reported. Here, I show the case of chimney stenting. After aortic valve cross and pigtail positioned in LV, transradial coronary protection is recommended to avoid interference with the THV device. Then THV is implanted with safety wire and stent at the mid of LAD. The coronary stent is retracted and deployed within the proximal part of the coronary artery, extending above the displaced leaflet tissue. Finally, confirms a good stent expansion and coronary flow. This is a case of sinus sequestration. The leaflet is longer than SOV height in pre-procedural CT. TAVR was performed under LCA protection with safety wire. After Sapien 3 implantation, LCA flow was disturbed. As it was impossible to deliver the device, another guide catheter was engaged through the strut of THV for PCI. TAVI-SAV holds higher risk of coronary obstruction than native valve TAVR, especially in the surgical valve of stented with externally mounted leaflets as shown in the left side figure. The risk is as high as 6%. To predict the risk, virtual THV coronary VTC distance is useful. On pre-procedural CT, simulate virtual THV with a specific diameter at each coronary level. You can see the red circles in the figures. They measure the distance between the red circle and coronary ostium, as shown with a white bar. The cutoff of 4 mm distance is reportedly useful to predict the obstruction. These are two example cases. On the left side, VTCs are 4.9 mm and 6.8 mm respectively. The surgical valve was Carpentier-Edwards Magnais, stented with internally mounted leaflets, so the risk is low. On the right side, VTC is 2.8 for LCA. The surgical valve was trifecta, stented with externally mounted leaflets. As the risk is high, and upfront coronary protection and chimney stenting are needed. Bioprosthetic scallop intentional laceration to prevent iatrogenic coronary artery obstruction, basilica seems to be an effective approach for preventing coronary obstruction by maintaining blood flow towards the coronary artery by intentionally created leaflet laceration using electrified wire. 95% success rate is reported. This is summary. Transradial coronary protection is recommended to avoid interference with the THV device. When the risk is high, standby stent within the coronary artery and chimney stenting work well. In cases with stable hemodynamics, re-engagement of guiding catheter through the THV strut, followed by stenting is optional for future re-intervention of coronary artery disease. Ideally, we should be familiar with basilica procedure. I'd like to conclude my presentation. Coronary obstruction during TAVI is a rare but devastating complication. Multiple anatomic, procedural, and valve-related factors contribute to this risk. Pre-procedural CT imaging is key to identify high-risk patients. In high-risk patients, we need to plan adjunctive procedures such as coronary protection using safety wire and stent or basilica to prevent coronary obstruction. Thank you for your attention.
So, thank you, Dr. Ichiburi, for the very good presentation about how to prevent coronary obstruction during a TAVI. So, we have one question for you about what kind of coronary stent you choose in case of chimney, or what kind of stent you choose, Bemol stent or cover stent or pleural stent for the chimney technique in case of high risk of coronary obstruction. So thank you.
Thank you for very good question. So I always wonder which stent I should use when I do the chimney stenting, but I think I prefer to use Giants cobalt chrome stent. You know the name? Giants. It's international name.
Yeah. It's similar to Vietnam.
Because it's a 3-link stent, so I believe it has stronger radial force to the aortic valve leaflet. So when you use a weak radial force stent, so the native leaflet may fracture the stent. So in that case, we use 2 stents at the LMT to keep the good radial force and the opening of the implanted stent.
So thank you, Ichibori, for your experience about the stent, coronary stent in the chimney technique when we do the TAVI. So now we will move to the next speaker. We would like to invite Dr. Man Chanda Vimon for the speaker for the presentation about how to optimize hemodynamic status post-TAVI, PVL, AVG, and without increasing risk of an annular rupture. Please welcome Dr. Chanda Vimon.
Hello, can you hear me?
Yeah, we can hear you.
Thank you for the invite. My talk today will be on how to optimize hemodynamic status. So focusing on PVL and gradient, as well as reduce the risk of annular rupture. This is my disclosure. With regarding to PVL, this is the authority sample that why PVL happens. You know that with TAVR, we do not remove the native aortic valve. So there's a chance that the valve may not seal completely, and that is the main result of the PVL. And we know that paravalvular leak or PVL increased mortality. This is true both the balloon expandable and self-expandable valve. Even with mild regurgitation is not necessarily a good thing. And that is translated into long-term or at least intermediate-term result as well. So we should aim for none or trace PVL if possible. Even with mild PVL, you have worse mortality outcomes at 5 years. And of course, if moderate, it's definitely not a favorable result. Predictors of PVL, it's multiple reasons, and I think we just need to try to identify what's causing it. Number one could be undersized device, incomplete prosthesis apposition, or because of the calcium of the valve itself, or another thing could be malposition of the prosthesis itself. So undersized device is also important. So the accurate measurements of the annulus is very important. But with that, also this is the early experience that if you use the XT valve and you oversize less than 10%, then you had more PVL compared to if you have more than 10% oversize. This percent oversizing is not true anymore with the new generation devices. Also, the accuracy of the measurement is important. So in general, these days we use CT guided, and that seems to have accurate annular measurements, and that itself can reduce PVL. Another thing that we all encounter is heavy calcification, and calcification can come from different forms. You can see leaflet calcification, annular calcification, there's a fused commissure, there's LVOT, and like saber tooth like this, including SOV calcification. But bottom line is all sort of calcification predicts PVL, LVOT calcium, if the leaflet calcium volume is high, or annular area is also all predicted of PVL. So both leaflet and LVOT calcium is predicted. So how can we prevent PVL? I think the device itself helps a lot. Sealing technologies, which I'll show you in a minute. Also proper sizing, the use of post-dilatation if safe to do so, and also health assessment. This is how the device has evolved over time. You can see the balloon expandable Sapiens system. Now we have Sapien 3 and Sapien Ultra, and you can see that outer skirt will help and without the need for too much oversizing. The Evolut system with the Pro and Pro Plus, and also the newcomers, for example, Accurate Neo also have a ceiling skirt, as well as the Portico family that had also a skirt now called Navitor. Next, I'll move to aortic root rupture. You can see that this is some sort of anatomy that definitely at increased risk of aortic root rupture when they have a calcium at the annulus and that at the LVOT. And with these, the predictor of rupture is LVOT calcium, as mentioned. If you oversize the processes too much, in this case more than 20%, you also had a very high risk of rupture, and also balloon post-dilatation. So this is the same message, is that if you oversize too much, definitely we try to avoid anything above 20%. This is the first generation, and post-balloon dilatation need to be judged properly. Next, I'll talk to you about the hemodynamic and patient prosthetic mismatch. We know that the larger effective orifice area, if we can gain, probably a better survival and probably a better durability as well. In general, the TAVR had less severe PPM as compared to surgical AVR, because we don't need a sewing ring, but in some instance, if the device did not expand properly, that could also still happen. When you look at the balloon expandable trials, like the partner trials, the risk of severe PPM is roughly about 12 to 15%, whereas the surgical arm is about 28%. It's much lower if it's being studied in the self-expandable supraannular design. The risk of severe PPM is 7% only. And in general, in the registries, the risk of PPM after TAVR is roughly about 10%. We all know that EOA will be higher with the self-expandable valve, mean gradient also lower, and DVI ratio is also lower. So I guess if you start off with the low annulus size, then self-expandable might be preferable to reduce PPM. Also, it will also depend on patient's body surface area. This is the chart of the Evolut and SAPIEN 3 in terms of a predictor of PPM. This is the label size, meaning that it's not a real measurement. So that you can see here in the red is a severe PPM, yellow is moderate PPM. So if you use Evolut and your body surface area is above 2.5, the risk of severe PPM is low. Whereas SAPIEN in the smallest valve, if your body surface area is above 2.1, you had a chance that you may get PPM. It is not a major concern if you have a bigger valve. Whereas this is also a surgical PPM chart, and you can see that the PPM happen more often in these surgical well processes as compared to TAVI for the reason I mentioned. Another interesting thing that I think we could talk about is the gradient. When we talk about PPM, it depends a lot on gradient, and we can see that just the way we measure the echo, the Doppler gradient in the self-expandable tends to be lower. But when we do it invasively, the direct hemodynamic, it was not a major difference. Nonetheless, our follow-up echo or to consider gradient post-implant still heavily rely on the Doppler gradient from echo. And that is another topic of discussion. It's just the way we measure the gradient and the design of the valve. But in these two cases, for example, the net mean gradient, which is supposed to be the more accurate way of measuring the gradient by measuring the LV and also aorta, just the level above STJ, similar. But when you do measure by echo, it tends to be higher with the balloon expandable or valvular design, 12 versus 9 in this case. And so that's something to be cautious about when we talk about high gradient afterwards. And this seems to be more often when you deploy a smaller balloon expandable system. When we look at that, this is the Ocean TAVI registry from Japan. Look at a small annulus patient. Obviously, the Evolut system will have higher EOA and less gradient, but that did not translate into all-cause mortality at all. And I think in Japan, the BSA of the patient is quite small. Maybe that's not as important. Whereas in France, this is just recently presented at TCT this year, showed that the XS tab we tried, so anybody had less than 23 annulus diameter, compare balloon expandable and self-expandable, and found that in a matched population, clearly much more significant moderate to severe PPM with the balloon expandable compared to self-expandable. And that severe PPM has in this trial translate into increased 3-year all-cause mortality. When look at the valve type alone, it's not statistically significant. Also, there will be a smart trials to enroll either Medtronic Evolut Pro or Pro Plus to step in 3 or Ultra with the patient with small annulus less than 330 mm square. So in general, I think to decide which system to use, basically, I think for the balloon, it's pretty quick, predictable, need rapid pacing, generally less PVL, less pacemaker required, short frame for future access, more radial strength, good access, less tilt. Whereas if you use the self-expandable, it's more recapturable, no need for rapid pacing, mostly supraannular design, taller frame except accurate neo, less radial strength, and then also less of annular rupture in high-risk cases. I'm just gonna show you 2 cases. First one is 75 years old, BSA 1.4, severe symptomatic, severe AS, low risk, mean gradient of 45 as shown. But the problem of this patient is that they have very small annulus, 15 times 23 with a mean of 19, area 279, perimeter derived 19, there's no calcium. SOV also small, 21 to 23 only. The leg is fine. So if we decide to use balloon expandable system with a 20 mm, it will be oversized almost 20%. And definitely we do not want to underfill the 20 mm sapien. So I think there's another options that we can use supraannular design. This is accurate neo 2, and we can fit in the side S or 23 mm. And this is what happened. Upper crown deployment, lower crown, and that's the results. And the gradient was very acceptable, was 6 prior to discharge. And then I have another case of 79 years old with severe symptomatic AS as well, also low risk, EKG as shown. This one had valve area of 0.5, valve area index of 0.5, mean gradient of 64, as shown here. And when we do in CT, we show that it's a calcified right and left raphe, as well as also a commissure non and left. So very heavy calcified bicuspid type 1. So when we measure the annulus, no calcium there, area 520, LVOT is similar. So if look at these alone, we will go for 26 mm, possibly nominal, but with the calcium and the bicuspid in nature, what we did was also the circle methods, and we also take into account of the non and left commissure calcification into account. And so we decide to go for 26 valve -2, and that's how we do it, pre-dilatation, and you can see that the balloon was eccentric, not in the central. Because of that calcified raphe, we deployed height. Sorry, yeah, that's okay. And that's the final position. You can see that the valve is tilted to the non-cus away from that calcified raphe. The good final position, no PVL, and the mean gradient afterward was 9. And that's the results. So I think in my conclusion, to get the best result for TAVR, to have no annular rupture, no PVL, and good hemodynamic, also on top of what other speaker has talking about coronary obstruction, coronary access, conduction abnormalities, durability and possible need for TAVR and TAVR. Basically, we just need a good pre-procedural planning, both clinical and anatomical planning. If possible, if we have different choices, proper device selection, choose the proper device. Some device can be at high risk. Some device for this anatomy could be low risk. So if possible, device selection is important. And then we do the procedure as planned or proper execution. Thank you.
Thank you, Dr. Shandavimol. Does the floor have any question for the presenter?
Thank you, Dr. Chan Davimon from Mahidol University. We learned a lot from your presentation about how to prevent PVL and AVG. So in the case that you present here, you use the esophageal echocardiography for the whole case of the TAVI procedure, or you just use the chance thoracic echocardiography for the TAVI procedure, because you measure the pressure gradient and also the parabolic. So which one is better for us when we measure esophageal or thoracic? Thank you.
Yes, we don't do transesophageal echo on a routine basis anymore because we don't do general anesthesia. We do thoracic echo. We have a thoracic echo in the room always. Do pre-procedure and post-procedure. So no need for transesophageal echo on a routine basis. Yeah. But I think the thoracic echo still needed to help assess the proper deployment, gradient, and PVL.
Thank you, Dr. Shandavimol. Time for our session is over. May I thank all the presenters and panelists of this session, and I hope to see all of you again in another congress. Thank you.
Thank you. Thanks.
Thank you.
Thank you.
Thank you.
Thầy cảm ơn toàn thể mọi người ha, tất cả các quý đồng nghiệp tham gia cái phiên này, và xin nhường lại cho chủ tọa đoàn của phiên sau. Xin cảm ơn.
It's a brand new day. It's a brand new day. It's
kỳ đại hội tim mạch và Hội Tim mạch Việt Nam đều là những sự kiện rất lớn trong cộng đồng tim mạch. Nhưng lần này sẽ rất đặc biệt. Dấu mốc lớn chính của đại hội ngày hôm nay là Hội Tim mạch Việt Nam sẽ trang trọng kỷ niệm 30 năm ngày thành lập hội.
30 năm, đó là một chặng đường dài đầy ắp những kỷ niệm. Từ những ngày đầu gian khó với vô vàn khó khăn cho đến ngày nay, chúng ta đã thu được rất nhiều các cái thành tựu đối với ngành tim mạch Việt Nam.
Hội Tim mạch Việt Nam từ khi được thành lập giai đoạn đầu tiên mà rất khó khăn như vậy, và hôm nay chúng ta đã có một cơ ngơi khá biệt thế. Đó là những cái thành tích về kiến thức y học về tim mạch. Chúng ta đã hội nhập sánh ngang vai với các quốc gia ở trong khu vực Đông Nam Á, và trong một chừng vực chúng ta đã có tiếng nói và sẽ có tiếng nói nhiều hơn trong cái thời gian sắp đến.
Đã thành thông lệ, Đại hội Tim mạch toàn quốc luôn quy tụ những chuyên gia, những nhà khoa học hàng đầu trong chuyên ngành tim mạch trong nước cũng như quốc tế, đem tới những chuyên đề mới nhất, cập nhật nhất và nóng nhất cho các bạn đồng nghiệp trong nước.
Đến với đại hội lần này thì chúng ta không chỉ tham gia những phiên khoa học hết sức bổ ích, mà chúng ta còn có dịp gặp nhau để ôn lại những kỷ niệm hết sức xúc động của Hội Tim mạch học.
Chào mừng đến với Đại hội
Tim mạch toàn quốc
kỷ niệm 30 năm Hội Tim mạch học quốc gia Việt Nam.
Các kỳ đại hội tim mạch và Hội Tim mạch Việt Nam đều là những sự kiện rất lớn trong cộng đồng tim mạch. Nhưng lần này sẽ rất đặc biệt. Dấu mốc lớn chính của đại hội ngày hôm nay là Hội Tim mạch Việt Nam sẽ trang trọng kỷ niệm 30 năm ngày thành lập hội.
30 năm, đó là một chặng đường dài đầy ắp những kỷ niệm. Từ những ngày đầu gian khó với vô vàn khó khăn cho đến ngày nay, chúng ta đã thu được rất nhiều các cái thành tựu đối với ngành tim mạch Việt Nam.
Hội Tim mạch Việt Nam từ khi được thành lập giai đoạn đầu tiên mà rất khó khăn như vậy, và hôm nay chúng ta đã có một cơ ngơi khá biệt thế. Đó là những cái thành tích về kiến thức y học về tim mạch. Chúng ta đã hội nhập sánh ngang vai với các quốc gia ở trong khu vực Đông Nam Á, và trong một chừng vực chúng ta đã có tiếng nói và sẽ có tiếng nói nhiều hơn trong cái thời gian sắp đến.
Đã thành thông lệ, Đại hội Tim mạch toàn quốc luôn quy tụ những chuyên gia, những nhà khoa học hàng đầu trong chuyên ngành tim mạch trong nước cũng như quốc tế, đem tới những chuyên đề mới nhất, cập nhật nhất và nóng nhất cho các bạn đồng nghiệp trong nước.
Đến với đại hội lần này thì chúng ta không chỉ tham gia những phiên khoa học hết sức bổ ích, mà chúng ta còn có dịp gặp nhau để ôn lại những kỷ niệm hết sức xúc động của Hội Tim mạch học.
Chào mừng đến với Đại hội
Tim mạch toàn quốc
kỷ niệm 30 năm Hội Tim mạch học quốc gia Việt Nam.
Các kỳ đại hội tim mạch của Hội Tim mạch Việt Nam đều là những sự kiện rất lớn trong cộng đồng tim mạch. Nhưng lần này sẽ rất đặc biệt. Dấu mốc lớn chính của đại hội ngày hôm nay là Hội Tim mạch Việt Nam sẽ trang trọng kỷ niệm 30 năm ngày thành lập hội.
30 năm, đó là một chặng đường dài đầy ắp những kỷ niệm. Từ những ngày đầu gian khó với vô vàn khó khăn cho đến ngày nay, chúng ta đã thu được rất nhiều các cái thành tựu đối với ngành tim mạch Việt Nam. Hội Tim mạch Việt Nam từ khi được thành lập giai đoạn đầu tiên mà rất khó khăn như vậy, và hôm nay chúng ta đã có một cơ ngơi khá biệt thế. Đó là những cái thành tích về kiến thức y học về tim mạch. Chúng ta đã hội nhập sánh ngang vai với các quốc gia ở trong khu vực Đông Nam Á, và trong một chừng vực chúng ta đã có tiếng nói và sẽ có tiếng nói nhiều hơn trong cái thời gian sắp đến.
Đã thành thông lệ, Đại hội Tim mạch Toàn quốc luôn quy tụ những chuyên gia, những nhà khoa học hàng đầu trong chuyên ngành tim mạch trong nước cũng như quốc tế, đem tới những chuyên đề mới nhất, cập nhật nhất và nóng nhất cho các bạn đồng nghiệp trong nước.
Đến với đại hội lần này thì chúng ta không chỉ tham gia những phiên khoa học hết sức bổ ích mà chúng ta còn có dịp gặp nhau để ôn lại những kỷ niệm hết sức xúc động của Hội Tim mạch học.
Chào mừng đến với Đại hội
Tim mạch Toàn quốc
kỷ niệm 30 năm Hội Tim mạch học Quốc gia Việt Nam.
Các kỳ đại hội tim mạch của Hội Tim mạch Việt Nam đều là những sự kiện rất lớn trong cộng đồng tim mạch. Nhưng lần này sẽ rất đặc biệt. Dấu mốc lớn chính của đại hội ngày hôm nay là Hội Tim mạch Việt Nam sẽ trang trọng kỷ niệm 30 năm ngày thành lập hội.
30 năm, đó là một chặng đường dài đầy ắp những kỷ niệm. Từ những ngày đầu gian khó với vô vàn khó khăn cho đến ngày nay, chúng ta đã thu được rất nhiều các cái thành tựu đối với ngành tim mạch Việt Nam. Hội Tim mạch Việt Nam từ khi được thành lập giai đoạn đầu tiên mà rất khó khăn như vậy, và hôm nay chúng ta đã có một cơ ngơi khá biệt thế. Đó là những cái thành tích về kiến thức y học về tim mạch. Chúng ta đã hội nhập sánh ngang vai với các quốc gia ở trong khu vực Đông Nam Á, và trong một chừng vực chúng ta đã có tiếng nói và sẽ có tiếng nói nhiều hơn trong cái thời gian sắp đến.
Kính thưa quý đồng nghiệp, như vậy theo sự phân công đó, thì hội trường chúng ta hôm nay sẽ thực hiện cái đề tài là cập nhật về triệt phá rung nhĩ. Thì về chủ tổng đoàn là gồm có tôi là tiến sĩ bác sĩ Tôn Thức Minh và tiến sĩ bác sĩ Trần Văn Đồng. Chúng ta sẽ có 4 bài báo cáo mà theo như cái bộ phận kỹ thuật của ban tổ chức cho biết đó, thì 4 bài này đều báo cáo hình thức là video phát. Thì chúng ta sẽ nghe qua video, và có gì thì chúng ta sẽ thảo luận. Chắc vì không online cho nên chắc không gặp được speaker, chủ yếu là chúng ta nghe thôi. Rồi xin mời bộ phận kỹ thuật bắt đầu ạ.
Rather in radio frequency or in cryoablation, you have Thank you very much. Now I want to share my screen.
Hello, everybody. I'm Professor Laurence Giselle from Strasbourg University Hospital. Thank you very much for the invitation, and I'm very sorry not to be able to be present with you today. My topic will be about persistent AF, which ablation strategy. We'll see first, what do we know about persistent AF? What was done before? Then we'll see pulmonary vein isolation, yes, but what else and for whom? And we'll see the three main strategies with fragmented potential, voltage-guided ablation, and Marshall Plan. So what do we know about persistent AF ablation? This ancient study from 2002 evidenced that in persistent AF, if you only do PVI isolation, you have disappointing success results because after 1 year, 40 to 50% only of the patients are in sinus rhythm, which is really not the same results than in paroxysmal AF. So what do we know about AF mechanism in persistent AF? Like in paroxysmal AF, pulmonary vein foci are involved in the AF, but also the body of the left atrium is remodeled, and this remodeling induces obstacle for the propagation of the electricity, and micro-reentrant atrial circuit can be involved, as well as rotor moving on the body of the left atrium. Cardiac innervation is also involved, and Marshall ligament. Concerning ablation strategy in paroxysmal AF, it's now well established that pulmonary vein isolation is the main important thing to do. In persistent AF, the substrate is more involved, so substrate modification ablation has to be done. Of course, the rate of success is getting worse when AF becomes persistent, and complication increases as you spend more time in the left atrium. This more recent meta-analysis on nearly 1,000 patients and 14 studies using RF and cryo shows that now the strategy of pulmonary vein isolation alone in persistent AF is associated with 66% of success at 1 year. With RF, lesions are wider at the antrum, and cryo also induces better lesions, so technology has improved. Whatever, when we do PVI, we have to obtain durable lesions. Indeed, contact force catheter have improved the way of doing lesion, and indices like ablation index show the quality of the lesion. High power, 50 watts, and very soon 90 watts will also improve probably the rate of success. And electroporation, this new technology, new source of energy, will also probably improve the lesion. Whatever, the problem now is to identify which patients will need more than pulmonary vein isolation. To answer this question, it's important to understand what characterizes the progression from paroxysmal AF to persistent AF. What is known is that an advanced atrial remodeling is involved. It can occur in 1 to 15% per year to 27 to 36% at 10 years. So AF is a progressive disease. The risk factors for progression are age, heart failure, hypertension, kidney failure, and diabetes, but also chronic pulmonary disease, stroke, and LA size. What is known is that this progression is associated with cardiovascular events, an increase in hospitalization and mortality. Whatever this progression is a factor or a marker of bad prognosis. It identifies a progression of the substrate. In the guideline, different strategies are described. PVI, lines, defragmentation, whatever, you have to adapt your strategy to the patient. What we know for sure is that ablation techniques are superior to antiarrhythmic treatment. In this study from 2014, they compared antiarrhythmic treatment to ablation. The operator could do PVI, lines, defragmentation according to local protocol. Whatever, in 70% of the cases, sinus rhythm was maintained in ablation group versus only 43% in the antiarrhythmic group. In this work from Bordeaux Group, they studied the 5-year outcome of catheter ablation persistent AF using termination of AF as a procedural endpoint. The results were quite good because we could observe a freedom from arrhythmia recurrence in 65% of the patients and 74% of the cases when antiarrhythmic drug therapy was maintained. Whatever, more than one ablation procedure was necessary in the vast majority of the patient, and procedural AF termination was a strong predictor of favorable outcome during the procedure. What was also described is that most recurrences are observed during the first year, and that progressively there's a slow decline in arrhythmia-free survival. Persistent AF ablation is still associated also with a significant procedural complication rate. Stepwise ablation strategy was done until recently, it consisting in defragmentation of active and rapid potential, but several studies have confirmed the limits of this stepwise strategy. The 5 years outcome is about 50%, but still you need multiple procedures to have this success rate. In 2015, STAR-AF2 was really a very important study. They compared 3 strategies of persistent AF ablation. 1, pulmonary vein isolation alone. 2, PVI plus complex fractionated electrograms. 3, PVI plus linear ablation. The results showed that cafe ablation and lines increased the time of procedure, so it increased also the risk. There was no benefit in adding cafe ablation and lines to PVI, and PVI alone evidenced no recurrence in 50% of the patients after 1 procedure, and the success was 72% after 2 procedures, which was a very good result. This study of Bordeaux Group, using MRI, tried to establish atrial structure and function 5 years after stepwise ablation. The scar in LA was quite important with 29% of the surface, and in RA scar was smaller but could reach 4.3% of the surface. LA contractility and compliance were markedly impaired years after successful persistent AF ablation, and LA dysfunction is closely related to scar burden. So we need a more efficient ablation to burn less and be more efficient. The study using CardioInsight system was very interesting. This system allows a non-invasive LA cartography. 252 electrodes on the torso record unipolar activity, and then with optical mapping you can build maps of the activity, and it helps to understand the substrate. With these maps, they could really target ablation of driver region. When AF was a long-lasting one, many driver regions were involved, and you need a lot of ablation to stop the AF. When AF was less than 6 months old, the results were better. The termination rate sharply declined after 6 months. At 12 months, 85% of the patients with AF termination were free from AF, which was similar to the control group with stepwise ablation. Persistent AF in the early months is maintained predominantly by driver clustered in few regions, most of them being unstable re-entry. A bit later, Bordeaux Group again targeted the ablation on specific electrogram patterns in low voltage area using high density mapping with, as you can see, persistent AF from 4 months. So they studied the impact of AF termination on AF late recurrence. The target were complex fractionated electrograms in low voltage area. First step was the PV isolation. Then low voltage area were mapped. 40% of the patient converted to ATAC or sinus rhythm after PVI or after ablation of low voltage areas. 60% of the patients were shocked.
Thank you. So dear organizers and dear chairman, dear colleagues, it's a great pleasure for me to be here at the 18th National Congress of Cardiology. And I want to also send the best greetings from the German Vietnamese Society of Cardiology. And unfortunately, for 3 years, it was not possible to go to Vietnam, and so I hope that soon we will want to start my presentation now.
Hello?
I'm here live
Yeah.
from Germany.
Yeah,
I'm Dr. Quang from Germany.
Yeah, Dr. Dong from Vietnam National Institute. Hello?
I can start my presentation now.
Yeah, you can start now.
Okay. Thank you very much. So, dear colleagues, best wishes from Germany, and I'm very happy, and it's a great pleasure for me to be here at your annual meeting. And I want to send you all the greetings from the German Vietnamese Society of Cardiology, and I hope that we will come back soon to Vietnam. And dear organizers, dear chairman, today my presentation is about advances in technology for atrial fibrillation, and I want to focus on a rather new technique that calls the so-called pulse field ablation, the PFA. So the history of electroporation. The electroporation was first described in the 1960s, and an electrical pulse will lead to increased cell permeability and then to irreversible cell death. So lipid membrane become unstable. There will become nanometer large bursts, so that leads to cell necrosis. And then for since 30 years, medical applications with electrochemotherapy leads to reversible increased cell permeability that we can use in chemotherapeutics in cell. So you see here, there's a cell membrane, the genes or drugs here outside. You do an electrical pulse, and then that leads to some permeability of the membrane, so the genes and drugs can go in the cell and do these effects. Well, that was reversible increased cell permeability, so the irreversible electroporation is being used in oncology, food science, wastewater management, and so on. And also the irreversible electroporation is probably the mechanism of the cardiac DC ablation in the 1980s. Well, then we come from the DC to the radio frequency ablation. You all know this publication of Breithart. In 1987, he has described the high frequency alternating current ablation of an extracellular pathway in humans. So that makes us the question that why go back when everybody was relieved that DC ablation could be abandoned when radio frequency ablation was introduced in 1987? Well, you all are familiar with the radio frequency and also the cryoablation, and there are still problems with thermal ablation. So you see here some scarring, tearing, phrenic nerve disturbance, phrenic nerve alteration, also atrioesophageal fistula. And so maybe energy reduction may prevent collateral damage. So look at the mechanism of the electroporation. You see here the membrane, the electrical pulse leads to a permeable membrane, so that leads to apoptosis. So the next step when regarding the electric field strength here, and the exposure duration, one can divide different areas with effects of the electrical pulse. And we have here this area of white, no detectable electroporation, and the green one, reversible electroporation. The darker green area with non-thermal irreversible electroporation, and the red area with high electrical field strength and long exposure duration leads to irreversible electroporation, but also thermal effects. And what is adorable, so favorable, is this dark green area with safe and durable effect of electroporation. Here is coming up the safety concerns, and here this area is there's only transient lesions. So what is the specificity of the electroporations? So we can see that there's a high tissue specificity of the pulse field ablation. So cardiomyocytes have a low ablation threshold. That in the third term of ablated cardiomyocytes, the nerve cells or esophageal smooth muscle cells or vascular smooth muscle cells, they were preserved. And so here is in this section of the histological preparation, and it shows an ablated area with preserved vascular. So in summary, you can mention that atrial cardiomyocyte have an tissue sensitivity of 400 volts per centimeters, whereas endothelium or musculature have 1,750 volts per centimeter, and the nerve with very insensibility with 3,800 volts per centimeters. So the pulse field leads to a continuous lesion here in the microscopic preparation. So that is then contact independent ablation. The pulse field ablation offers an ablation modality that is proximity dependent, meaning the catheter electrodes must be close to the tissue target, but it is not essential to have direct contact. And the ablation leads to a continuous and transmural lesion. The resultant lesions are contiguous and transmural in the shape of the electric field. And so I want to show you again in histological preparation that you can see here the ablated tissue here with preserved intralesional arteries here, and preserved epicardial fat tissue. We're one of the first catheter system with the pulse field ablation is the so-called FARA-Pulse catheter. This is a catheter with a basket and flower design, and you can advance it, the catheter, in the pulmonary veins. Here, you can see it here, to put the flower configuration and to ablate the pulmonary veins with pulse field ablation shocks. You can see here that it's possible to eliminate the pulmonary vein electrograms. And so that's my friend in our group from the CAS Niven. We have the first experience with pulse field ablation as routine treatment for paroxysmal atrial fibrillation. And you see here the catheter advance in all the 4 veins with a flower configuration. And this is a typical paroxysmal atrial fibrillation cohort. And we have skin-to-skin procedure time about 116 minutes. Interesting is the fluoroscopic time, about 26 minutes. I understand there's a little bit of the learning curve. Total number of PFA application per patient and per vein is that in the medium you have about 8 PFA applications, 8 PFA applications per vein, and we could isolate all 100% of the targeted pulmonary veins. And you have to imagine that one pulse field ablation is only about 40 to 60 millisecond. So here the 3D mapping after ablation with the pulse field ablation system. You see here all the pulmonary veins are well isolated with the antral isolated. And with this catheter, it's also possible to ablate induce linear lesions. Here you see the mitral isthmus ablation with a pulse field catheter. So interesting is regarding the parameters of troponin, CK and CKMB. There is an elevation in troponin, CK and CKMB with a peak after 6 hours and then return to normalization after 30 days. And when you compare it to the, for example, compare it to the cryo system, the value, the troponin and CK/CKMB is much lower than when comparing to a cryoablation procedure. So Vivek Reddy have published a few years ago a rather very good clinical success rate with the pulse field ablation system with nearly 90% after 1 year. Success rate, freedom of AF, flutter and atrial tachycardia. And when looking at the other studies with concerning success rate, radio frequency, energy balloons, pulse field ablation might be superior, but of course it is only one study, and we need some more data, and we need some more long-term data about this new technology. And also Wilhelm's group from the Hamburg have published last year the possibility to induce substrate modification, induce linear lesions in the left atrium with the pulse field catheter system. So ladies and gentlemen, dear colleagues, I want to summarize my talk for today that the pulse field ablation is a form of irreversible electroporation that uses a train of bipolar and biphasic pulses of high voltage and short duration to create tissue injury without significant healing. And a unique feature of pulse field ablation is tissue specificity. Myocardium is very susceptible to irreversible injury, whereas the esophagus, phrenic nerve, pulmonary vein, and coronary arteries are relatively resistant to injury. In patients with paroxysmal atrial fibrillation, the pulse field rapidly and efficiently isolates PVs with a degree of tissue selectivity and a safety profile heretofore not described for cardiac ablation. And furthermore, invasive electrophysiological studies demonstrated that pulse field ablation can achieve a high degree of durable PV isolation. And I want to thank you very much for your attention.
Thank you very much, Dr. Quang. Can you hear me?
Yes, I can hear you.
Okay. Yeah. Very interesting presentation. I have a question for you. Your methods for AF ablation you presented very new article published in the March 2022, right? So I want to ask you, comparing with the methods in AF ablation with high power, short duration, your methods is better than or it's the same result?
Thank you for the good question. And we in our center, we also use the high power and short duration. And I from the history, I'm growing up with the radio frequency, and with the high power and short duration settings, we use the settings from the N-side X system. And in my opinion, the radio frequency ablation with the high power short duration is safe, and it's also effective comparing to the pulse width ablation. I think that in my opinion, the pulse width ablation is not better than the high power short duration ablation.
Okay, thank you very much. Because we did some kind of hyper short duration, and the result very good. Thank you.
Very good.
Yeah. Thank you very much, and hope meet you this year or next year in Vietnam, right?
Yeah.
Okay. Thank you. Goodbye.
Thank you.
We end that
Goodbye.
presentation. Yes. Shilin Chan, em có bài chưa?
Yes. Hi.
Yeah. Good afternoon.
Good
How are
afternoon.
you?
Yes. So I have a pre-recorded video. So for me, have a live presentation or just play my video?
Depend on you. Which is convenient for you?
So maybe we can play the video.
Yeah.
And then we can have a discussion.
Yeah. Okay. And if
online,
I had a
yes.
question, I can talk with you, right?
Yes, sure.
Video đó rồi chưa?
Good afternoon, ladies and gentlemen. I'm Dr. Shilin Zhang from Taipei Veteran General Hospital, Taipei, Taiwan. Today, my talk is how to approach redo air vibration. This is my outline today. First of all, I'd like to talk about the characteristics of recurrent atrial fibrillation. There are some mechanisms of atrial fibrillation recurrence after catheter ablation. In terms of recurrence, tissue inflammatory response to catheter ablation, a transient imbalance of ANS, progressive maturation of the ablation lesion are the mechanism for the early recurrence. For the late recurrence, reconnection between the PV and the LA could be the possible mechanism. For the very late recurrence, non-PV triggers remodeling of abnormal substrate is responsible for the mechanism. From our study, we found that the 10 years outcome of paroxysmal atrial fibrillation ablation is suboptimal. For a single procedure, the long-term efficacy is around 55%. For the multiple procedure, the long-term efficacy increased to 88% with 1.2 procedures. For the 10 years outcome of non-paroxysmal atrial fibrillation ablation is even worse. The single procedure, the long-term efficacy is only 19%. After multiple procedure, the long-term efficacy increased to 55% with 2 times procedures. And we found after the increase the incidence of non-PV triggers as the procedure section increased. PV reconnection is still dominant in the repeated procedures. So how about the impact of different types of atrial fibrillation in recurrence? In this figure, we can divide the patient into 3 groups. One is paroxysmal atrial fibrillation, Second is persistent atrial fibrillation. The third is long-lasting persistent atrial fibrillation. As you can see, in patients with the non-PV trigger, in all three groups, there are lower successful rate, which means the higher recurrence rate compared to those without the non-PV triggers. Therefore, the patient with atrial fibrillation originating from the non-PV presented with worse outcomes in different types of atrial fibrillation. So interestingly, we found that in the smoker patients, there is a higher incidence of non-PV triggers. And in all the patients, it seems there is no difference in the recurrence between the patient with smoker and without the smoker. However, if we look at the patient with smoking, for the patient with the RA non-PV trigger has a higher recurrence rate compared to those without the RA non-PV triggers. So in terms of non-smokers, there seems no any impact of right atrial non-PV trigger in the recurrence rate. For the second part, I'd like to talk about the ablation strategy for reduced air vibration, focusing on the PV reconnections. As we all know that the PV reconnection is still the majority mechanism for the recurrence. So we have to confirm the complete PV isolation in the reduced case. So in the reduced case, we will routinely check the PV potential and confirm the PV isolation. And the second part, we will try to propagate any possibility of non-PV triggers. And finally, we will try to induce any the atrial arrhythmia, such as atrial flutter or atrial tachycardia. So nowadays we have a high density mapping tool catheter, and in different the company they have a different type of the high density mapping catheters. In the Airbus group, they have a HD group. In the Biosense, they have a Pentarate, and in Boston, they have a Orion catheter. They have a different electrode size and also a different electrode spacings. And for the high density mapping, we know they will have a better resolution for the structure mapping, and also the identify the some potentials. Here is an example showing that the useful of high density mapping for the detection of reconnection of PV gaps. In the left side hand, you can see use the Pentarate, which has a 1 millimeter electrode. You can identify the gap in the posterior wall of ISPV, shown here. However, if we use the conventional or the catheter, the thermocool, which has a 3.5 millimeter the electrode, you cannot identify any PV gap. So in the Orion system, they have ultra high density mapping for searching PV gap. And in this the movie, as you can see, we can use the activation map, propagation map to identify the PV gap. It's shown here, and also the voltage map shown here have some residual tissue property here. And further operation strategy for the reduce the edge operation is focusing on the non-PV trigger. As we know that the edge operation is not only from the pulmonary vein, but also can from the other part of the atrium, such as the SVC, right atrium or left atrium. So we have to identify the possible edge operation trigger. So before we search the non-PV trigger, we have to understand how to do the provocation test to identify the non-PV trigger. In terms of process of edge operation, we can use isoproterenol 1 to 4 microgram per minute infusion to induce the trigger. And then we can perform the burst pacing. Adenosine can also be used to provoke the edge operation. If edge operation was induced and you cannot find the PV trigger, you can perform the electrical cardioversion to obtain the sinus reason. After that, we have to pay attention to any PV APC which can induce the edge operation. And we have to do twice to confirm the AF orange. In terms of non-PV, non-process of edge operation, and if sinus reason during the operation procedure, you can do it as a non-proximal edge operation. If edge operation noted and sustained after PVI, you can identify the rotor. You can use some software and upgrade it. If edge operation still persists after operation, you can perform the cardioversion to see if PV or non-PV trigger, and then induce as above if we. So P-wave morphology of ectopy is very important because you can help us to localize the orange of the trigger, and we can go there and have a detailed mapping. So here I show you there's a different P-wave morphology in the different orange of the atrial arrhythmias. Of course, there's several algorithms of the P-wave morphology you can use. In our group, we developed a type pair approach of mapping during the sinus reason. And if you find an ectopy initiate edge operation, then you can use the difference between the high RA and the His interval as a criteria. If there is more than 10 and more than 0 milliseconds, then you can appreciate this could be from the left side, and then you can use a CS proximal to CS distal interval to differentiate this from the distal CS first or proximal CS first. If this difference is less than 0, it could be from the right side, and this time you have to map the SVC or Quist analysis. For the more detail, you can search our previous paper for more detailed information. This slide shows you the trigger or originating from the SVC. SVC is also a arrhythmogenic part which can develop some trigger, initiate the edge operation. So it's very important part to search the non-PV trigger. we can put some catheter, such as a circular catheter or deca pole catheter in the SVC, and to wait to see any initiation of atrial fibrillation from here, which can confirm the SVC trigger. If SVC trigger was identified, then we will perform the SVC isolation. Of note, before you perform the SVC isolation, you have to identify the SA node first, and try to avoid the isolate the SA node. Left atrial posterior wall is also an important part for the trigger of AF, because the posterior part sometimes they have some arrhythmogenic subject. So if the posterior wall trigger was identified, you can perform the posterior wall isolation. And of course, some study they use the voltage guide MRI to guide the subject operation. And also some center they use some software to identify the rotor in the posterior wall. And sometimes the trigger may from the inside the coronary sinus, as we know that CS have some muscular layer, and also this could be a arrhythmogenic subject, and we have to detail mapping in the CS. And also some trigger may originated from the vein of Marshall. In this slide show you that before the operation, as you can see in the operation signal, you can identify the potential followed by the legal Marshall potential here is very sharp potential, and then followed by the PV potential. And after that, we can eliminate the LOM. And sometimes we will be confused by the LOM potential and the PV potential. So we can do some maneuver to differentiate the VOM from the PV potential. We can pass from the left atrial appendage and also pass from the CS distal part, which is very useful to differentiate the PV potential from the VOM potential. And if we found this to be the VOM potential, then we can perform the external infusion to eliminate the VOM potential. So here show you that from our previous study, we found the VOM external infusion with PVI and the linear aspiration in patient with non-proximal atrial fibrillation may have a higher AF-free survival rate compared to the patient who received the PVI and the linear aspiration, and also the PVI only. So in this survival curve, as you can see, the VOM external infusion seems have can improve the AF-free survival outcome. And another interesting site for the trigger is aortic encroachment, which is in the LA upper second part. In this area, you can see here the aorta may have some compression to the LOA. This is a this is a junction between the aorta and the LOA. So there's an aortic encroachment area over the LOA, which may cause some arrhythmogenic here. And in this figure show you that the atopy from the aortic encroachment area, and with some very fractionation interval here, and can initiate the atrial fibrillation. And after the ablation of this area, the atrial fibrillation was terminated. And this is a 3D reconstruction showing that the aorta here, this will be a compression of left atrium here. Left atrial roof vein is not very common, but sometimes it can trigger the atrial fibrillation. So in this case, as you can see here, in the roof area, there is a roof vein here. And in this case, there's some roof potential here, which can initiate the atrial fibrillation. So after the isolation and ablation of the roof vein potential, it can prevent the atrial fibrillation. So, ladies and gentlemen, this is my take-home message. The PV isolation is still the cornerstone of atrial fibrillation operation, especially for those with redo the operation. But non-PV triggers should be identified in the redo procedure, because some non-PV could not be identified in the first section. So in the second section, you should try your best to propagate the non-PV trigger. Linear ablation lesions should be approached with caution, and should be reserved for the patient with flutter, because if you do too much ablation or night in the left atrium, it may cause more abnormal subject, which may induce some iatrogenic arrhythmia. Thank you for your attention.
Good evening, ladies and gentlemen, and thank you very much for the invitation to participate in the Vietnam National Heart Association Congress. I'm Dr. Thu Nguyen Lim, one of the cardiologists working in Singapore, and today I've been asked to talk about integrated care for atrial fibrillation. As you may be aware, atrial fibrillation is one of the most common arrhythmias in the population, and occurs in about 0.5 to 1% of the general population in Singapore. Based on the Singapore Longitudinal Aging Study, it is present in about 1.5% of the population over the age of 55, with a preponderance in males. However, as you'd expect, in those over 80 years old, the prevalence is higher at about 5.8%. In Singapore, the majority of these cases are non-valvular. However, the use of oral anticoagulants, while clearly indicated in these patients, is very low. This is a study I did a few years ago with some medical students looking at patients admitted to a tertiary hospital ward with atrial fibrillation, and we found that only a minority of them were treated with warfarin, and of these, only 44% of them were in the therapeutic range. And in spite of having a high stroke risk, again, only a minority of them, 44 of 119, were actually discharged on warfarin. And not surprisingly, the patients who are not on warfarin had a worse outcome in terms of stroke-free survival on follow-up. This is reflected in more recent studies. This is the Garfield Registry, of which Singapore was one of the participating countries. It is a global registry of newly diagnosed atrial fibrillation. And in this rather kind of complicated looking chart, you'll see that down the bottom of the x-axis are bars representing patients with different levels of CHADS scores, CHADS-VAS scores. The Singapore graph is on the left, and the one for the world population is on the right. And you will see that in these graphs, the blue bars represent patients on vitamin K antagonists. The brown and orange bars represent those on non-vitamin K antagonists, anticoagulants. And the green bars are antiplatelet therapy, and purple bars are those on nothing. And you'll see that across these columns, regardless of your CHADS-VAS scores, you'll find that the use of anticoagulation is both incomplete and also inappropriate use of antiplatelets across all ranges of CHADS-VAS scores. While there's a generally lower use of oral anticoagulants in the Singapore population, compared to the rest of Asia, we do use more non-vitamin K antagonists. So why do we do so poorly in terms of optimizing treatment for these patients? And this is a study that was done by one of our PhD nurses. And they found that although physicians had good knowledge of stroke risk and how they should use that to manage patients, there is poor translation of knowledge into practice, such as not anticoagulating patients with AF when they need to. And there are also many barriers, things like concerns about falls risk, contraindications to oral anticoagulations, etc. And several strategies were proposed to overcome these. The other thing that we also found was that the levels of knowledge about atrial fibrillation was very low in our population. These are AF knowledge questionnaires that we validated in our patients in our clinic. And during this study, we found some shocking numbers of the patients who are on anticoagulation. So these are patients having warfarin for AF. Only 16% of them knew what they had, and that was atrial fibrillation. Whereas, although a larger proportion of them knew that they were on anticoagulation for stroke prevention, very few knew about other treatment options for atrial fibrillation. Hence, it has been proposed that a way to overcome these many issues with AF care is to use a system called integrated chronic care. Basically, it is a response to the shortcomings of physician-centric models of care that predominate in the hospital system, and also an emphasis on technology-enhanced service, together with an expanded role for allied healthcare workers. This is a simple kind of breakdown of the main principles of integrated chronic care that I borrowed, the slide borrowed from Professor Hendricks. And basically, there is a protocolized guideline-based care for the treatment of what is a complex disease, both in terms of the treatment of the arrhythmia, management of AF-related complications, treatment and management of cardiovascular morbidities, as well as risk factor and lifestyle management. There is an emphasis on professional relationship between the team members, and typically a multi-disciplinary team focused on guideline adherent management. And finally, and just as importantly, a patient-centered approach with a strong emphasis on patient involvement through patient education and self-management, as well as self-shared decision making. So this is built out of a landmark paper by Professor Hendricks, which randomized the care of patients in a tertiary hospital clinic to a nurse-led atrial fibrillation integrated chronic care clinic versus usual care by cardiologists. And in this study, the nurse-led arm was actually supported by a clinical decision support software focusing on guidelines-driven and protocolized care. Interestingly, in a relatively short study and a relatively small study of about 700 patients, they were able to show that not only was there improved adherence to guidelines in the nurse-led clinic, there was actually a reduction in cardiovascular hospitalization and deaths. This led to the inclusion of integrated AF management as part of the European Society of Guidelines. And these are the latest ones from 2021. And you'll see that it states the main principles of that not only is there optimized stroke prevention and also the usual symptom control and management of risk factors. There's a strong emphasis on patient education and self-management with lifestyle modification and psychosocial management, using a multidisciplinary team approach and with strategies to promote medication adherence. This has to be considered now to be standard of care for our AF patients. How about implementing this in primary care where most of AF patients are? Well, this has been extended in a study by Venden Riese and his colleagues in a cluster randomized clinical trial of a quarterly AF nurse clinic randomized in a cluster. In other words, some clinics had the AF nurse clinic, whereas other clinics relied on usual management. There was an emphasis on case management, oral anticoagulation, as well as easy access to anticoagulation and cardiologist care. And interestingly, this study showed that there was a reduction in all-cause mortality in the nurse-led arm. However, what is interesting also is that this was predominantly driven by non-cardiovascular mortality, and hence there were questions about whether a selection bias was present in this study, as patients were allowed to opt in or opt out of the arm. And furthermore, 41% of the patients in the nurse-led arm actually still had regular cardiologist appointment. Nonetheless, I think this shows the promise of this approach in a primary care setting where the majority of AF patients are. So how do we apply this to our region? Well, we tried to use this in Singapore. As you know, Singapore has gone through a rapid half century of industrialization. And 50 years ago, our clinics looked a bit like this, where they focused on infection control, screening for TB, vaccinations, and things like that. However, these days, they have evolved greatly into modern facilities, which mostly deal with chronic diseases now. One of the big advantages of these large polyclinics, as we call them, is that there's a wide range of facilities, including physiotherapists, there's retinal photography rooms, apart from the usual family clinic rooms, as well as a pharmacy. There's also X-ray and laboratory services in these clinics as well. So what we tried to do was to implement a new model of care to deal with the shortcomings of our current model. As you know, what normally happens these days, when an AF patient comes to a primary care doctor, they get referred to a cardiology clinic in a tertiary hospital. And these patients then go around in an endless circle of expensive tests and long waiting times. Some get expensive procedures and interventions, and they keep following up in the clinics. If not, then they go back to primary care. However, in our integrated AF chronic care clinic in primary care, what we do is that our primary care doctors can directly order some specialized tests, things like transthoracic echoes, Holters, even stress ECGs. These then get reviewed in a team review clinic where both a doctor, a family physician, as well as an advanced practice nurse decide whether the patient is suitable for primary care. If they do, then they enter the nurse-led integrated chronic care clinic for chronic follow-up. If not, then they will end up in a cardiologist clinic that is run in primary care. Those who are too complicated and difficult, of course, get referred back to the tertiary hospital. But those who are deemed to be not so difficult, then also follow up in a nurse-led integrated chronic care clinic. And this is what it looks like in the clinic. And this is Ms. Liao, who is one of our advanced practice nurse, seeing one of our patients. She is in charge of their long-term care with a strong focus on education. And part of the thing we do to enhance the education is that we have built a website where we include a lot of educational material. There's a predominance of videos because that's what patients like to see. It is available in both English and Chinese and accessed through a QR code here, as you can see. We not just talk about the disease itself, but also about lifestyle modifications as well. So how does this do in our clinic? Well, we've done only some preliminary evaluation of this clinic, as much of the data collection was hampered by the pandemic. but we recently published very early results of this, where we looked at patient-reported outcomes. First of all, we should note that there was no difference in cardiovascular hospitalization and stroke incidence within this very small group of patients. So I'd have to say this is very preliminary studies, but suggest that this approach is safe. On the other hand, in terms of patient-reported outcomes, there was a clear improvement in quality of life in the nurse-led clinic patients. There was a clear improvement in their knowledge scores, medication adherence, and also reduction in their depression scores, which was very, very heartening for us to find. In terms of the preliminary results of this study, I'd have to say that the nurse-led primary care clinic can provide a safe and effective AF care in the community through a high-quality patient education and counseling by trained nurse practitioners. They felt that there was more personalized care in this setting, especially with a consistent team of healthcare providers managing their care. Also, a comment that patients often made was the convenience of having their concomitant chronic conditions reviewed with their AF conditions as well. So what have we achieved? Well, currently in Singapore, this is what chronic care for AF looks like. The light yellow patients are the ones with simple disease. The orange ones are the ones with intermediate disease, whereas the red patients are the ones with complex disease. And you'll find that currently patients with high care needs or low care needs are all mixed up, whether they are in general practice, outpatient cardiology, or in the hospitals. However, we hope that what we can achieve with this integrated chronic care model is that the low complexity patients will remain in the general practice, whereas the medium to high complexity patients with higher care needs can be looked after in outpatient cardiology as well as the hospitals. By doing so, we hope to be able to optimize the use of our limited resources, especially in this time with a growing number of AF patients in the community. So in summary, AF is a looming epidemic. It is one of the fast-growing conditions in a community, and our current hospital-centric care models simply cannot cope with this. We think novel models of care, perhaps such as the integrated care model, are needed to improve the outcome and the care delivery system for these patients. We think a tech-enhanced integrated chronic care is the way to deliver this cost-effective care. Finally, I'd like to acknowledge the team that has worked with us, Dr. Bridget Wu, who is one of our research fellows now at the School of Nursing, as well as the large team of nurses and APNs at the Bukit Batok Polyclinic, as well as the project vector team who have helped us implement this model. Thank you very much for your attention.